Shalina Healthcare presents Rising Stars Season 4 Grand Finale, a unique platform for medical professionals to showcase their clinical talents. Who will be the next winner? Over 786 doctors across the country participated in the qualifiers. The top 10 finalists from 17 hospitals will compete at the grand finale. Who will walk away with a 1.2 million naira grand prize? Join the Shalina family in our quest to find out our next stars. Prizes: first prize 1.2 million naira, second prize 700,000 naira, third prize 400,000 naira, and there will be consolation prizes. This year's Rising Stars will be held physically on February 11, 2025 at NECA House, Alausa, Ikeja, Lagos. Virtual participants can watch live on Stream TV's YouTube and Facebook channels. Subscribe, like, and click the notification bell for instant updates. At Shalina Healthcare, we partner with medical professionals to deliver quality care for all. Shalina Healthcare, celebrating 40 years of trust.
Is there anything you want to say to me?
So? Take some. It has the power of 5 natural active ingredients that clears your throat when you need it the most. Shout to get your voice back.
My tutu. I don't want to live without you tutu. Will you marry me?
Think natural. Think shout.
Your Honor, my client is not guilty.
Then let me say that it is not guilty.
Sir, I'm guilty.
It has the power of 5 natural active ingredients that clears your throat when you need it the most. Shout to get your voice back.
Your Honor, I am not guilty.
Then you are free to go.
Think natural. Think shout.
Mom, Dad, it's time to get up and brush your teeth.
Oh, I don't want to brush my teeth.
But it's not just any toothpaste, it's Rodent.
Oh, the one with the ingredients that give strong white teeth?
The one with mint for all day freshness?
Well, in that case, we will happily brush our teeth.
Packed with the long-lasting freshness of mint. For fresh breath every day, Flodent toothpaste. Your kids will love it and you will too. Flodent. Grab life, grab the freshness.
You should be the next singing superstar.
Has dull and uneven skin tone taken away your confidence? Presenting Shalina Healthcare's new Epiglow. With power of triple radiance complex and innovative technology that gives you glowing skin by reducing dark spots in 28 days. Skin science for a perfect glow. New Epiglow. Skin science for a perfect glow. New Epiglow.
As a mother, I'm always ready to keep my family safe and healthy.
Mom, we won the match.
I'm proud of you, son. Well done.
Thank you, Mom.
It's time to fight the germs. Jamo soap? Hey there, little hero.
Miss Jamo?
Want a football match?
Yeah.
Now it's time to win against germs with Jumbo Shower.
Jamo, it's all in one. Care and protection till the job is done. Jamo.
Good morning, everybody. Good morning. We're about to commence the program. First and foremost, apologies for the delayed start. It's due to reasons beyond our control. We are trying to get more of the guests in-house, the audience, so we can have a full participatory house. However, we also understand the challenges we face in the country. The issue of JAPA. So most doctors, they've JAPA. The ones available are being held in the consulting rooms, majorly because of our patients. So I believe we all understand why we have a less filled house. However, in the course of the program, I believe more of the audience will join us. Okay, so welcome to this exciting event. A round of applause for Shalina Healthcare. A round of applause for the doctor fraternity. Because we are here because of you. We know the role you play in the society. So that's why we make it mandatory as a company that we have to celebrate our key stakeholder in the doctors fraternity. So without wasting further time, we would like to start by having an opening prayer. And in our usual tradition in Shalina Healthcare, we recognize all religion. So we do our opening prayer by way of our national anthem. So can we be upstanding, please? DJ.
Nigeria, we hail thee, our own dear native land. Through trials of Nigeria, in brotherhood we stand. Nigerians honor and proud to serve as a sovereign motherland. Our flag shall be a symbol that truth and justice reign. Peace of to the world, and this we count as gain. To hand unto our children a banner of without stain. O God of the whole creation, grant peace upon the rest. Help us to build our nation, where no man is oppressed. And so with peace and plenty, Nigeria may be blessed.
Thank you very much. So I should also mention that this event is being held virtually. So aside those of us in this room, I can assure you, pan-Nigeria, we have people glued to their YouTube, glued to their the Shalina MedSpace platform, and they are viewing these events. So it's not just those of us in here. And to our virtual audience, we say, welcome to Rising Star. Did I hear someone? Chuba, you're one of the virtual audience now. Say something. Oh, we can see our virtual audience. So at this point, I would like to introduce someone very special in Shalina Healthcare. I've decided to name her the guardian angel, okay? Because she directs the affair of what we do, Shalina Nigeria. And she's been doing a tremendous job, okay? And she's no other person than the head Nigeria pharma business, Shalina Healthcare, in person of Mrs. Okpeyemi Abisola. A round of applause for her as she comes forward to take the opening address.
Good morning, distinguished ladies and gentlemen. Shalina partners and our rising stars here present in this hall. It is my absolute pleasure to welcome you all to this edition of Shalina Rising Stars Award, which incidentally coincides with Shalina at 40. So I welcome you on this note to felicitate with us at Shalina Healthcare on the 40th year of our existence across the African continent. Shalina Rising Stars Award is indeed special to us, as it is a means for us at Shalina Healthcare to invest in the future of our leaders, to invest in the future of the upcoming leaders, upcoming group of innovators and game changers. And that is what Shalina Rising Stars Awards is about. To recognize, inspire, and reward the set of game changers that we have identified over the past couple of weeks. So today, I encourage you to sit back and relax as we get into the series of events that marks today's episode of Shalina Rising Stars Award, which promises to be an exciting one, cerebral one, considering we're going to be listening to doctors. I'm especially enthused and anticipating what we're going to see, what we're going to witness today, and looking forward to identifying the best of the best and the creme de la creme in the medical field. Once again, I welcome you all to the event, and I hope you enjoy the rest of the day. Thank you.
All right. Thank you. Standing on existing protocol, I want again, because I've been in the forefront trying to relate with the assessors and finalists today. Just like we started in over about 17 institutions, going through, having to interface with over 700 resident doctors, young fellows. That has culminated having the 10 finalists that we have today. So without wasting much time, I would have the singular honor to call on our finalists, one after the other. They already have their seat numbers. When I call her, read out your citations, you come in and rightly take your seats. So, starting off. All right, first is Dr. Akinola Odedeji. Graduated from Olabisi Onabanjo University, Agowe, State with a bachelor's degree in medicine and surgery in 2012. Completed residency training in Ife. Obtained a certification of achievement in research ethics from the World Health Organization in 2024. Obtained the educational certification of the American Board of Artificial Intelligence in medicine in 2024 as well. Obtained international certificate of radiology fundamentals from Radiology Across Borders, University of British Columbia, Canada in 2025. He is a member of the Nigerian Medical Association, a member of the Association of Radiologists of West Africa, fellow West African College of Surgeons, member Society of African International Radiology and Endovascular Therapy, member African Organization of Research and Training in Cancer, member European Society of Radiology, member Radiological Society of North America. He won the first prize National Medical Association and National Essay Competition on Medical Brain Drain in 2020. The principal investigator in an ongoing study, randomized control trial of a low-cost vacuum-assisted breast biopsy device for breast cancer diagnosis, funded with a grant from the Association of Radiation and Clinical Oncology of Nigeria. The co-investigator in multiple international grant-funded studies, domiciled at OAU THC Ife, has published 4 research papers in leading international and regional peer-reviewed journals. He loves public speaking. Please join me as we welcome Dr. Akinola Odedeji. Thank you for coming. Next is Dr. Abiye Somiari. He graduated from the University of Port Harcourt with MBBS in 2012. He's a consultant in the Department of Community Medicine, University of Port Harcourt Teaching Hospital. He holds a Master's of Science in Public Health, Epidemiology. He's a member of Nigerian Medical Association, Association of Public Health Physicians of Nigeria, Epidemiological Society of Nigeria, International Epidemiological Association. He's a fellow of National Postgraduate College of Nigeria. He is currently the Secretary of the Epidemiological Society of Nigeria, Rivers State Branch. He is a recipient of 2 departmental awards, as well as the Dr. O.P. Sogbetu Prize for the Best Candidate in Part 2, FMCPH, examination 2024. He loves traveling, watching movies, and playing tennis. Please jam your hands as we welcome Dr. Somiari Abiye. Welcome, sir. Next is Dr. Ridwan Okpayemi Mustafa, graduated with MBBS from Bayero University in Kano, 2014. Had his residency training at Federal Teaching Hospital in Katsina from 2019 to 2024, consultant radiologist at FTH Katsina from 2024 till date, the member of Nigerian Medical Association, Medical and Dental Council of Nigeria, fellow West African College of Surgeons, Islamic Medical Association of Nigeria, National Association of Resident Doctors, Association of Radiologists in Nigeria. His achievements include, but not limited, Chairman, Electoral Committee and Audit Committee, Association of Resident Doctors, Federal Teaching Hospital Katsina, most outstanding senior resident, Department of Radiology, Federal Teaching Hospital Katsina. He was also a finalist in the Shalina Grand Finale Season 2 in 2022. He loves reading and writing. Please join me as we welcome Dr. Ridwan Okoyemi Mustafa. Next is Dr. Okoro Ichena. Dr. Okoro Ichena is a holder of the PSC Human Anatomy, MBBS from University of Port Harcourt. He holds an MSc in Health Management, the Fellow of Medical College of Radiology, Fellow West African College of Surgeons. He's a member of the Association of Clinical and Radiation Oncologists of Nigeria, member Association of American Society of Clinical Oncologists, Paul Harris Fellow, Rotary International. His achievements include, but not limited, author and co-author of academic papers in peer-reviewed journals, collaborator in both local and international clinical trials in breast and prostate cancer, and he loves board games and traveling. Please join me as I also welcome Dr. Okoro Uchena. Next is Dr. Joshua Ebuka Ifebude. He had his primary education at the First Baptist Church Nursery and Primary School in Ilorin, Kwara State. Graduated from Baptist Model High School, Ilorin, Kwara State in 2005. Graduated from University of Ilorin, Kwara State, MBBS in 2013. He's a member of West African College of Surgeons, Part 2 Fellow of National Postgraduate Medical College in the Department of Obstetrics and Gynecology, University College Hospital, UCH Ibadan, Oyo State, from 2024 till date. He's a member of Nigerian Medical Association, Medical and Dental Council of Nigeria, Association of Resident Doctors, ALD, UCH Ibadan, National Association of Resident Doctors, NALD. He has keen interest in medical research and has co-authored 13 articles in both local and international journals, co-investigator in WHO Action, antenatal corticosteroid for improving outcomes in preterm newborns, prior, 2019, co-investigator in WHO Action 3, antenatal corticosteroid for improving outcomes in preterm newborns, trial 2022. That is currently ongoing. Best graduating student in the preclinical class, University of Ilorin 2013. Overall best graduating student in science class, BMHS Ilorin in 2025. He is married to Mrs. Glory and blessed with 2 boys. Hobbies includes volleyballing and traveling. Please welcome with me Dr. Joshua Ebuka Ifebude. Next is Dr. Ayotunde Eniola Oyeleye, graduated from Aladoke Akintola University of Technology, Ogbomoso, with MBBS in 2008. He had his residency training in pediatrics at the Department of Pediatrics, Federal Medical Center, Bida, Niger State. Had subspecialty training in hemato-oncology and University of Abuja Teaching Hospital, Gogalada, and National Hospital, Abuja. He's a member of Nigerian Medical Association, Medical and Dental Council of Nigeria, member of Medical and Dental Consultants of Nigeria, a fellow of the Faculty of Pediatrics, National Postgraduate Medical College of Nigeria. He has co-authored articles such as Current Trends in the Management of Acute Kidney Injury, Prevalence of Hypertension, Diabetes, and Chronic Kidney Disease in participants of the World Kidney Day screening exercise in Southwest Nigeria. Awarded the EMSO Award for the best candidate in pediatrics, Part 2 examination, National Postgraduate Medical College of Council of Nigeria, May 2024. He loves traveling and rural outreaches. Please welcome with me Dr. Ayotunde Eniola Oyeleye. Next is Dr. Ifunaya Olarima Ebiekwe. Studied medicine and surgery at the University of Nigeria, Nsukka, 2011. Works as a senior registrar in the Department of Pediatrics, University of Uyo Teaching Hospital, Akwa Ibom State. Postgraduate certificate course in pediatric nutrition by Boston University School of Medicine. Postgraduate certification course in pediatric rheumatology by European Alliance of Associations for Rheumatology. She's a member of the Nigerian Medical Association, Medical Women Association, fellow West African College of Physicians, member National Postgraduate College of Nigeria. She was first runner-up South-South Region 2018 Young Health Professionals Nutrition Quiz by Nestle Nutrition Institute of Africa. Second runner-up abstract presentation, World Scientific Conference AGM of the Nigerian Society of Pediatric Cardiology, November 2022. First runner-up abstract presentations, 5th Scientific Conference AGM of the Nigerian Society of Pediatric Cardiology in November 2024. She loves reading and writing fiction. Please join me as we welcome Dr. Ifunaya Ebiekwe. Next is Dr. Ugbebo Zegboya Vivian, graduated from the University of Benin with MBDS, Bachelor of Dental Surgery in 2006. She's a member of West African College of Surgeons 2020, fellow of West African College of Surgeons 2024, fellow Medical College Dental Surgery 2024. She's also a member of Nigerian Medical Association, Medical Women Association of Nigeria, Medical and Dental Council of Nigeria, Nigerian Dental Association, National Association of Oral and Maxillofacial Pathology and Medicine, International Association of Oral and Maxillofacial Pathology and Medicine. She has authored and co-authored of articles such as Association between socio-demographic factors and occurrence of oral autoimmune conditions in a tertiary hospital, a case of malignant transformation of leukoplakia to squamous cell carcinoma in a patient with HIV, a case of vulvogingival
86 doctors.
A case of vulvogingival syndrome, pemphigus vulgaris, and treatment complications. She loves reading novels and counseling. Please join me as we welcome Dr. Vivian Ugbebo Zegboya. Dr. Oluwole Olusegun Ogunwumi graduated from University of Ilorin with MBBS in 2012. Senior Registrar in the Department of O&G, University of Ilorin Teaching Hospital. Is a fellow of the National Postgraduate College of Medicine in Obstetrics and Gynecology. He is a member of Nigerian Medical Association, Medical and Dental Council of Nigeria, Association of Resident Doctors, Association member, Associate member, Association of Fetal Maternal Medicine Specialists of Nigeria, member West African College of Surgeons. He was a winner of the Best Abstract in 2024 Annual General Meeting of the Association of Fetal Maternal Medicine Specialists of Nigeria. He loves traveling and playing checkers and drafts. Please join me as we welcome Dr. Oluwole Olusegun Ogunwumi. Welcome. Last but not the least, Dr. Rukaya Nasir Soni, graduated from the Bayero University, Kano, with Bachelor of Medicine, MBBS, receiving the award for overall Best Medical Graduate. Cardiologist in the Department of Medicine, Aminu Kano Teaching Hospital, Kano State. Master of Public Health, Global Non-Communicable Diseases from the University of Edinburgh. Fellow of the West African College of Physicians, Nigerian Cardiac Society, European Society of Cardiology, Nigerian Medical Association, Medical Women Association of Nigeria, Associate Fellow of National Postgraduate College of Medicine of Nigeria. A.O. Shebanjo Prize for Best Part 1 Female Clinical Candidate in Internal Medicine of the National Postgraduate Medical College of Nigeria. Young African Leaders Initiative, Mandela Washington Fellow, Commonwealth Scholarship Alumna. USCDC and Lancourt Commission on Hypertension Emerging Authors Program. Bongani Mayosi Collaborative Seed Grant for Cardiovascular Research Excellence in Africa. Former Curator, Global Shapers Community, Kano Hub. She loves traveling and train rides. I'm sure Dr. Rukaya will get enough train rides in Lagos before you go back. So, join me as we welcome Dr. Rukaya. Thank you very much. You are welcome. As I said, we had a pool, we were exposed to over 760 doctors across the nation. And these are the 10 best brains that we have brought here to deliver to us, to give us their best. And I'm sure we're going to have a swell time listening to these amazing young fellows. All right. Going next, call on our national assessors. These are men and women of timber and caliber. They have been with us through thick and thin, right? And this is season 4. They started with us right from season 1. And whatever we are seeing today, right, whatever we are going to showcase today was part and parcel of their ideas, which we appreciate and continue to appreciate and we continue to celebrate them. So it is a huge honor. Otherwise, an honor beyond me. Otherwise, I would have called on our MD to introduce them. But I have to go ahead of our managing director to take our place to introduce these cerebral minds. After this presentation, you will agree with me that we have brought to you a crop of cerebral minds, assessors, national assessors in the medical field in Nigeria and the world today. Please, as we start, let us meet Professor Adamu Alhaji Samaila. Professor Alhaji Samaila graduated from the famous Ahmadu Bello University, Abu Zaria, with a Bachelor of Medicine and Bachelor of Surgery in 1993. He underwent the residency program of the West African College of Physicians and was awarded a fellowship of the college specializing in gastroenterology and hepatology in October 2002. He was appointed lecturer in the Department of Medicine by University Kano in December 2002 and rose through the ranks to become a professor of medicine in October 2015. He has been an honorable consultant gastroenterologist in the Department of Medicine at Aminu Kano Teaching Hospital from 2022 till date. Professor Samaila underwent a 1-year post-fellowship advanced endoscopy training at the University of Witwatersrand, South Africa, and the affiliate Chris Ani Baragwanath Hospital in Soweto, Johannesburg from November 2026 to November 2027. He has more than 60 publications in peer-reviewed local and international journals. He has delivered more than 100 guest lectures, scientific papers, and seminars at local and international fora. Research areas of interest include gastrointestinal endoscopy, Helicobacter pylori, and functional gastrointestinal tract disorders, especially non-ulcer dyspepsia and irritable bowel syndrome. He is an external examiner and external assessor to many medical schools and Nigerian universities. Has been an examiner with the West African College of Physicians for more than 2 decades and currently serves as the quality assurance representative for the Faculty of Internal Medicine on the Faculty Board of Internal Medicine, West African College of Physicians. Prof is a recipient of several merit awards and a member of many professional bodies. Appointed as a consultant physician by Aminu Kano Teaching Hospital in December 2022, the position is COC today. He is widely traveled across the world, married to a pediatrician, and blessed with 5 children. Please join me as we welcome Professor Alhaji Samaila. Thank you, sir. Thank you for coming. Next, our delectable, beautiful Dr. Afiongo Boku Oku. She is a chief consultant community physician with the University of Calabar Teaching Hospital and an associate professor with the University of Calabar, Cross River State. She is a fellow of the West African College of Physicians, Faculty of Community Medicine, Community Health. She holds a PhD in public health from the University of Oslo, Norway, and a master's in public health from the prestigious University of Ibadan, Oyo State. Dr. Oku was immediate past head of the Department of Community Medicine, UCTH, and University of Calabar. As an academician, she has published over 40 original articles in many peer-reviewed local and internationally reputable journals and has presented her works at national and international conferences. She has supervised several master's and PhD students. She has also worked as a consultant to several international agencies, WHO, USAID, the Initiative for Equal Rights, Pathfinder International, CHAMPS Nigeria, etc. Dr. Oku is passionate about training and mentoring the younger ones, especially young women, and ensures that she provides them with the right skills to excel. She has also a passion for teaching and transferring knowledge to her students and always leaves a lasting impression on her supervisees and mentees. She is also a 2-time award recipient for the Best Mentor, Best Trainer, organized by the Association of Resident Doctors, University of Calabar Teaching Hospital. Also, just this month, last year, she received a meritorious award from the Vice Chancellor as one of the 10 best heads of the department, University of Calabar. Our research interests include health communication, maternal and child health, qualitative research, and health policy and management. She is happily married to Dr. Oboku Oku, and the marriage is blessed with 3 amazing children. Please join me as we welcome Dr. Oboku Oku Wedoma. Thank you. Next, Professor Stephen Odunayo Ikuerewo is a professor of urologic surgery and consultant urologist with the Lagos State University College of Medicine and the Lagos State University Teaching Hospital, respectively. He had his medical degree from the University of Ibadan and graduated as the best student in the College of Medicine of the University of Ibadan in 1997, winning many prizes and awards. His medical postgraduate training was at University College of Ibadan and Medicine School or Schula, Hanover, Germany. For those of us that speak German language, you understand. I know Professor Aimaku understands Dutch. Right. He also won prizes and awards at the postgraduate level and was honored by National Postgraduate College of Nigeria. Since appointed at the Lagos State University, he has done highly impactful research and has published extensively on prostate and kidney cancers and general urology in several local and international journals. He has more than 65 publications to his name in reputable local and international journals. In addition, he has presented research papers and spoken at several conferences. He has successfully supervised at least 15 postgraduate dissertations for both National Postgraduate Medical College and West African College of Surgeons. Professor Ikeja popularized the operation of radical retropubic prostatectomy for early prostate cancer in Nigeria. Professor Ikeja enjoys traveling, taking a walk in nature, swimming and watching football, even though he can't play football. Right. Professor Ikeja is happily married and blessed with children. Please join me as we welcome our highly cerebral Professor Stephen Odunayo Ikeja. You're welcome, sir. Please, if we clap more, it will work faster. Thank you very much. So, thank you all once again. Beautiful audience. We have our finalists. We have our assessors. You agree with me, right, that we are, as I said earlier, we're in for a swell time. So I crave your indulgences. Please keep your minds open. I'm sure we are going to take home today one or two things. I know those that attended previous sessions, previous seasons. It's a Rising Star. They still speak. They speak of what they gained. They're always eager to comfort. Some could not be here and they are watching us live, right? But for those that are here today, I can assure you that they are also convinced and persuaded that they won't leave here empty. They're going to leave here something tangible, something to improve their medical knowledge through our finalists here. So thank you all. Thank you for coming. Thank you. Next, please, media, Shalina video.
At Shalina Healthcare, we started nearly 40 years ago, and it was based on an understanding that Africa needed quality medicines at an affordable price and that were available there on the ground.
We see ourselves as part of our vision to be Africa's health champion.
We are focused on Africa and we serve a whole host of countries across sub-Saharan Africa. So we started in DRC. From there, we went to Angola, then to Nigeria, Ghana, and French West Africa. Then on the east side of Africa, we're in Kenya and Zambia. And we're expanding every day.
One thing that I believe differentiates Shalina Healthcare from other pharmaceutical businesses on the continent is that our approach to each market is almost unique.
And so that means that we really understand the markets that we're in and how exactly to do business. We are a healthcare company focused on pharmaceuticals, consumer health, and diagnostics. As part of our growth ambition, we're entering into new therapy areas and new businesses. We believe in local manufacturing in Africa because it is important that the countries we serve become self-sufficient for their medicines.
Shalina Healthcare has historically always sourced its pharmaceuticals from either India and China. And in the last 5 years, we've strategically decided to expand our manufacturing capabilities onto the continent, made in Africa for Africans.
All of the plants that we manufacture in, be it our own plants or third parties that we partner with, all meet WHO GMP standards as well as the local regulatory requirement of every single country that we're in.
Good manufacturing practice, along with the quality controls, give us what we call quality assurance.
We'll also be entering into new countries in North Africa as well as South Africa. And we're going to do that by really building on the strengths that we have, where we really understand Africa and what its needs are.
This profound understanding has ignited and fueled our growth in consumer product range, expanding our current portfolio and crafting a robust go-to-market strategy across Africa and Middle East.
If you travel to any part of Africa, people recognize this company. So our products are very popular across the continent. And if you see the customers who come to our shops, for them, we are the first choice.
We are really committed to community outreach. We bring doctors, we bring nurses, we bring testing capabilities, giving them free medical attention and giving them free medicines.
In Shalina, most important are our people. We take care of our employees. We help them to develop themselves.
We don't struggle to be creative. We don't struggle to innovate.
The pursuit of our excellence not just stop at employees, it's also at the level of customers. Like the Shalina Young Talent Award for identifying the best talents in the pharmacy, or with a program called Rising Stars for the doctors when they are doing their internship.
I feel proud. I'm in the company 22 years. Healthcare has improved a lot.
We're committed to being in Africa. We've been there 40 years. We will certainly be there 40 years from now.
We want to have a lasting legacy where people can see the impact that we are making on the lives of millions in Africa.
Then we use case studies. The following year, we also use case studies. So we started using dissertations last year after getting some feedback from assessors and some top gurus of the medical profession. So we started using dissertations. And last year we had 17 at the grand finale. 17 were here for the grand finale. And this year, we also had, we had 17. But eventually we had to subject to a second level screening to bring down to the top 10. So as much as possible, I want to tell us that at Shalina we view these as much as possible. These are budding talents in the clinical field. Much as we won't encourage Japa syndrome, right? Dr. Larry Ma, I want to use Dr. Larima. She's already smiling. Much as we want to encourage Jackpot syndrome, we want to see to whom much is given within the country. Please give it back to us in this country. Stay back, help us. Right. The likes of our assessors, I'm sure, if they have also Jackpot, they won't be here today to also help improve our clinical talent. So it is our belief, it is our joy that as much as possible, we also contribute to the medical field, the medical profession in Nigeria, by organizing the Rising Star, bringing together bright, amazing young doctors to showcase their clinical talents, right, for some established experts in the medical field. And that is why we believe and know that at the end of every season, that there's no way attendees, both physically and online, will not take something back, not take something home. It is our joy always that we're going to fraternize. We're going to fraternize with the medical family. Much as we are also a pharmaceutical company in the drug business, but we also try to give back through our corporate social responsibility. What we are doing here today, we also did one last week for the pharmacies. Right? We held out for the pharmacy, for final year pharmacy students. We were here last week. This place was filled to the brim. And this week, today, 1 week after, we are here. So it's just to tell you that Shalina, much as we also contribute, we try to contribute, to give back to the medical family. Not just to come to you, to tell you about our products, to tell you about our brands, to tell you to write, but also to let you know that as well as possible, that we can also partner and improve our clinical outcomes. So, please. Right, let me just run through. This is our corporate slide. So, we pride ourselves with a vision to Sub-Saharan Africa's health champion with brands that people love and trust. And our mission stands on the tripod of quality, affordability, and availability. And our purpose today as a company in Africa is to make access to quality healthcare a right for all Africans so they can lead healthy, productive lives. And in doing so, we contribute to the social and economic growth of the continent. So we are driven by purpose, as we said, over 1,000 registered products across the continent, across 13 therapies rather. We are market leaders today in DR Congo, Angola, and Nigeria, and we're over 1,600 plus employees across the African continent. We have 49 brands, over 1,000 brands. 49 of those brands are in the $1 million category. They play in the $1 million category. In the pharmaceutical industry, that's a huge success for any pharmaceutical company. And we have 49 of our brands bringing in $1 million every year. Next. So our strength brand that people love and trust, you can see for over 40 years, we've been marketing most of these brands. And I'm sure you would have seen or come across some of these brands. Next. Right. Still showing some of the brands that you know. This is our cardiovascular range, the Telmisartan H, Rosuvastatin, Shalina Aspirin. Next, please. Then our focus to drive focus, we have a manufacturing plant right here in India, right? And that is where it's a WHO GMP compliant factory in India. It's accredited by the ISO 9001-2008, and it's also accredited by leading what do you call them? Leading regulatory agencies in Africa. For example, in Nigeria, our brand is recognized and approved by NAFDAC in Nigeria. Next. Right. So, first of its kind, Shalina did not start in Nigeria, right? But the first manufacturing plant in Africa is situated here in Nigeria on Lagos-Ibadan Expressway. State-of-the-art equipment, modern equipment. And for those that have the privilege, please, even if you can't go in, please, whenever you travel on Lagos-Ibadan Expressway, you may just cite it. And if you cite it, please, you may WhatsApp chat me and tell us thank you. First Shalina factory in Africa, technology transfer with installed capacity of over 5.2 billion tablets in a year. Currently, we run with solid dosage form, the quality management system in place. We are also targeting, for now, WHO certification, and we tend to serve the ECOWAS region when it's fully 100% operational. Next. Right. So our leap, our vision is to be a $1 billion company, and that we are working towards, and also to be able to serve 1 billion people in the years to come. Next. Right. So we have, as you see, our employees, we have our pride to be associated with our patients, our customers, healthcare professionals like you, right? Wholesalers and retailers, and our employees. It's always a vicious circle, and we revolve joyfully with this. This remains our pride. Next. So pride for our customers from selling to learning. Right. So we also organize Shalina Learning Centers, where we have our learning center in our office, where professional bodies come in, hold their conferences, hold their seminars, free of charge. And we also, apart from free, holding it free, rentage free, we also give out our products free, and we also give refreshments. So we have the learning center, which those in Lagos can come, conferences can come and use. Rising Star program, as we are today, is one of the programs which corporate social responsibility which give back to you. And you also know that it's a symbiotic relationship. As we are giving, we also expect that we also give back. It shouldn't be parasitic. It shouldn't be commensal. So it's symbiotic. Thank you all. Right. So also Shalina Young Talent Award for final year pharmacy students. As I said, the grand finale was held last week, where we also brought in 10 top bright final year pharmacy students to this hall, and we chose and celebrated the top 3. We also participated in conferences, NMA, NAIP, both pharmacies, medical, radiology, ophthalmology, whatever conferences we participate. We have a dedicated corporate arm, corporate department in charge of that. We are also, on special days, we also try to recognize and to celebrate our special healthcare professionals, our special customers, so we show gratitude to those that partner with us. Partnership with professional bodies in the country, as I said, with lots of professional bodies, PSN, NMA, SOFPON, we partner, SOGON. We partner with you and ever ready. Next, please. So also, pride for our customers, Shalina, on the job training platform for doctors, we have our med space. We also try to ensure that doctors also register on our med space, where you can be equipped, you can be acquainted with modern trends in the medical fraternity. We have a dedicated medical team right there in our head office in Dubai that source for current information in the medical field. And these are posted on the med space. And that's what we're going to encourage you. Please log in, join the med space. For those that have not joined, please, our staff, our colleagues are on ground. Link you up to that space. You need to join, because current and modern trends in medical practice would always shared on that page. So we also have our mobile health clinic where we do researches. We go to marketplaces. We have some medical personnel amongst you that will do health outreaches. We conduct some few malaria tests, blood pressure tests. We do DDC and what have you, just to get our people up to good health. Policy kit for government. We collaborate with policy makers like NAFDAC and etc. just to keep health in check and going. Pride with our patients. Patient camps, as we said earlier, we have the diagnostic lab, right? The Shalina Diagnostic Lab, where you can go in with modern equipment, current modern equipment, where you can go in, get tested, and get a result one hand, right? Personalized live teaching style coach, Shalina VOT, to answer different queries coming from our customer. We also try to get feedback from you. Whatever you think we need to do to improve, we are ever amenable. And I can assure you that we have the platform for that, especially when you come across any of our colleagues. Smart packs, patient education. We also put together valuable addition for the patients on usage of the product. We try to also encourage our patients. We try to guide patients on the usage of our brand, of our product. Apart from whatever you tell them, apart from whatever the pharmacist tell them in the hospital end, we try to also guide them through usage. The market clinics, as I said, We also go to the market, to the clinic, to the communities to try to organize some few medical outreaches. Next. So, as I said, many value-added initiatives to the benefit of our stakeholders, knowledge sharing, capacity building, patient-centric, customer-centric, all within the Shalina family. Next, please. So, Shalina MedSpace, gateway to limitless learning. As I said, please, we encourage all doctors. Please, you need to register on Shalina MedSpace. Very simple. In 2-3 minutes, this will be done. We provided the link, you do it, and you're going to get updates as medical information comes. Current medical information, I can assure you that we have a dedicated medical team in Dubai that does that. They search for medical current researches, information that you need. Even when you need some information, you can also go to that space, type your questions, they will reply you and source for your needs. That I can assure you. Right. So, masterclass program, we also do the masterclass program, 5 digital, sometimes, most times, both physical and digital online. And also through our webinars, we bring in resource persons from across the world to take sessions like that. Right? Next. Shalina Expert Panel as well. We sponsor expert gatherings to discuss Nigerian medical practice and the way forward. Also, it could be also 5 digital, physical, and online as well. Next. So, you can see how we started. Shalina Antibiotic Stewardship. Right. This, we have established the antibiotic ABS in several hospitals. I'm sure some of you will corroborate these, that we've been able to establish the ABS in some of the hospitals. Right. The antibiotic stewardship program, where we try to align with you, align with the hospitals on the effective use of antibiotics and the rational use of antibiotics. We guide and provide information from leading stakeholders about the rational use of antibiotics. Next. Right. So, marketing innovations, capacity building, and knowledge. Right. Then, international webinars, local webinars, academic sessions. Please go on. Right. On-site trainings at the Shalina Learning Center, monthly newsletter. We also have a monthly newsletter where we send, for example, after this session, we have your email addresses. Our dedicated team right there in Dubai. Monthly, we have, every quarter, we call it the Synapse newsletter. They bring up also news about medical practice across the world, and they send updates to you. But at your leisure, you can go to read and get some information. So, Shalina Learning Center, as I said, is facility designed for trainings. It could sit up to 120, free access to various HTTP sessions to train members. And we have about 6 of that built across sub-Saharan Africa. Next. Right. Newsletter and therapy, as we said, please go on. Say that. We care for the indigent, medical services, go on. Shalina Market Clinic, as I said, we go to the market and also try to take care of our people in the market. 21 markets so far, over 11,500 plus treated and attended to. We have been to 5 states of the Federation, bringing free medical care closer to our people. Next, please. Also, health education, medical checks and tests. All right, go. So you can see pictures at the Shalina Learning Center. This is our Shalina Learning Center where they have come in. No, now, going to Rising Star, let me quickly just tell you, it's a unique platform, right, as we said, for medical professionals to showcase their clinical talent. That is what we are here for. Next. So, in this highly dynamic era of science, exchange of ideas and experience and guide residents to deal with challenges in daily practice. At Shalina, we partner with medical fraternity by providing platforms that can add value to their clinical practice. Rising Star will provide a platform to boarding doctors to interact with renowned experts from the respective specialty. Next, please. Right. So it's a value-added initiative, and as I said, we started from the zonal hospital contest, where champions or winners came forth, and the winners were subjected to second-level assessment before arriving at the top 10 that are here for the grand finale. So a day of better. All right. Don't worry. Please, let's go. So this is a flyer to announce today. First prize 1.2, second prize 700, third prize 400. And that's why we're going to throw it at the finalists. Who will be the star? Dr. Kwebo, are you ready to be the star? All right then. Okay. Dr. Okoro is not responding. All right. So Rising Star journey to the finals. I said we went through the institutions at the hospital level, conducted this Day of Rising Star to select the winners, and they were all subjected to second level assessment before arriving at the top 10. Next. All right. The season 1, Dr. Adebayo Olaolu of Urology Department, FMC Award, right, was the maiden winner of the 4 Shalina Rising Star. And then we went through 60 case report entries were received from 36 institutions, participated in Nigeria, all across the 6 geopolitical zones. And you can see the feedback from the doctor and from Dr. Godiya Ishaya, the national president of NERD, who said then, this is a very good way of rewarding excellence in our profession. We are very impressed with what we are seeing here today. We thank the organizer for providing this great platform for learning and education. We also congratulate our members who are participants in this contest. We are very proud of you all. It is a fact that you are all winners here today. So, thank you. Next. So, that's season 1. Season 2 was won by Dr. Taiwo Folashade Elizabeth from Internal Medicine Department, University of Abuja Teaching Hospital. And there you see her celebrating. Right. Next. Where the top 3 winners then. First, the third person, Dr. Igwe Eval from National Orthopedic Hospital, Igbobi. Dr. Taiwo Folashade from UATH from Abuja. And the second player, Dr. Oluchukwu Joy Ogwai from UNTH, came second that year. And last season was Rising Star season 3. The best brain was Dr. Oluwadare Lere from Pediatrics Department, University College Hospital, Ibadan, won the prize. And these are pictures to celebrate him. Right. So the first, second, and third, as you can see. So at Shalina, together, we try to make a difference. That is what we stand for. That is why we are here today. And as I say, Shalina is a wholly African company. Right. Dedicated for the well-being of all Africans. And that's why we expect that you take this company, take Shalina to heart, please. Whenever you see any of our products, please know that they stand for quality, they stand for availability, and they stand for quality, efficacy, and affordability. And that's why we encourage you, please, as you partner with us, I'll be sure that we're going to do that will also help improve your clinical talent across board. So while thanking you again on behalf of the management of Shalina, I want to bid our finalists, please be at peace, enjoy yourselves. Let us get the best that you have to offer us today. And I'm sure the audience are all waiting to take 1 or 2 things home from you. So just go on straight to the big fight now. All right, before we go on, please, I will crave your indulgences. Please, we have our head of pharma business, West Africa. He just came in from a busy schedule. Please join me as we welcome our head of pharma business, West Africa, Mr. Amitav Basak. Thank you very much. All right, so straight off we go to the big fight, the presentations. The finalists have their seat numbers. They will be recognized by their seat numbers, and they will be coming sequentially from their numbers. So, are we ready? The first presentation. Please let me put out the ground. Please sit. Thank you. The first what we'll do, this session will take 6 minutes for presentation. Each presenter has 6 minutes to do justice to their slides. Right. Then we have 2 minutes of question and answer after each session. 2 minutes of question and answer involving 3 questions only. not more than 3 questions from the audience and the panelists. Please, 6 minutes for the presentation, 2 minutes for question and answer, and that will involve 3 questions from audience and not more than 3 questions from the audience and the panelists. Right. I hope we are in the order. Our assessors are set. We have the scoring parameters, right? And I'm sure our finalists are also ready as well. Right. So this is a session where we call the big fight. This is a big fight. So we expect to get the best from our people. So without much ado, if I don't have, am I okay? The finalists, are you okay with instructions, As? Are you okay with instructions? All right, so we can start off. Assessors, are we ready? So we start off.
Just to recap on that, 6 minutes for each of the sections. I'll tap on the mic when you have 1 minute left. I will tap this way to signify that you have just 1 minute left. Right. So if the assessors are ready, we're ready. So, Dr. Ayodeji, please remember, once you have 1 minute left, I will tap on the microphone like this, just to signify that you have 1 minute left. All the best.
Good morning, esteemed judges, ladies and gentlemen. I'm presenting my research that was on abdominal fat and stroke, following this outline. Okay, so why did I study stroke? Because Sub-Saharan Africa bears the world's highest stroke burden, and obesity is an established risk factor. But wait, what if I tell you that majority of African stroke patients are not obese? Unlike Europeans and Americans, where you find about 80% of the stroke patients being like this. Sorry. All right. In Africa, you have majority being like this. And this creates a dilemma. And some authors have suggested that perhaps obesity is not as important a risk factor for stroke in this environment. But there's emerging research to suggest another possibility. That there are people who may be thin on the outside, with normal BMI, yet possess dangerous levels of visceral fat hidden in their bodies. This has been described as a thin outside, fat inside phenomenon. The excess fat in these persons may not be detectable by the standard anthropometric measures that we use like BMI and waist circumference, but it continues to increase their risk for cardiovascular events like stroke. To the best of the author's knowledge, there's no published Nigerian study that has evaluated the role of thin outside fat inside phenomenon in the alarming stroke rates that we see in this environment. So I set out to compare intra-abdominal fat thickness between acute ischemic stroke patients and healthy subjects using ultrasound and identify if there are hidden fat depots that may be linked with stroke and assess if they correlate well with our standard anthropometric measurements. It was a comparative cross-sectional analytical design where we recruited 40 acute ischemic stroke patients and 40 matched healthy subjects. Matching was based on age, sex, and BMI, making a total of 80 subjects in all. Ultrasound was used to assess 3 key fat depots, 1 the visceral, 2 the peritoneal, and 3 the perineal fat thicknesses. And these were compared with standard anthropometric measurements. We did the relevant statistical analysis as shown. These are the ultrasound measurements of the visceral fat and then the perirenal fat. So what did we find? Our study revealed 4 key findings. Number 1, for the first time, we generated evidence of the thin outside, fat inside phenomenon in the Nigerian stroke population. How, you may ask? Number 1, you can see on this BMI distribution chart, the majority of our stroke patients, majority of our stroke patients actually were not obese. 60% had normal BMI. Either normal or underweight. 60%, meaning that they were thin outside. But when we went in to look at their abdomen with ultrasound, we found a totally different picture. We found that the stroke patients, the blue bars, had significantly higher levels of internal fat compared to the LD patient, the LD group represented by the green bars. And this was significant across all the fat depots that were evaluated. So they were essentially fat inside. If you put these 2 findings together, they were thin outside by BMI standards, then fat inside with ultrasound measurements. And what does this mean? If we use BMI to assess obesity-related risk, we're going to meet a lot of people. Our second key finding was that of all the fat depots that were evaluated, perirenal fat, the one around the kidneys, showed the largest association with stroke, strongest association with stroke. The odds ratio was 2.1, which was about double that of the next in rank, the visceral fat. Telling us that the fat around your kidneys is not just another fat depot. SARS and MAS, it is a fat depot that is strongly linked with stroke. We now want to find out, our standard anthropometric measurements, are they useful for assessing this fat depot? We found out that although they assessed the visceral fat depot adequately, they could not for perirenal fat. They didn't reach the threshold of 0.4, which is the threshold for moderate significance. What does this mean? It means that people may have normal anthropometry, but it doesn't tell us they have extensive perirenal fat, and that put them at risk, and they may not know it. Having established perirenal fat as a critical fat depot for ischemic stroke, and then since the anthropometric measurements cannot adequately assess them, we now went out to decide a cutoff that would predict stroke in our environment, and it was 5.93 in males and 5.78 millimeters in females, with an area under cuff that was really good, 0.9 and 0.88 across the male and female genders. Our findings, and this shows us, if you have 5.9 millimeters, don't expect that your waist circumference tape measure may pick these changes, but they're very significant. 1 minute left. Our findings align with that was young et al. And others who have highlighted perirenal fat as having disproportionate metabolic impact on cardiovascular risk. This is the first study that has explored the association between thin outside fat inside phenomenon and stroke. And then we found out that perirenal fat is the most associated with stroke. And remember, the parameters may not be able to evaluate it. And then we established a cutoff for the first time in this environment, which was 5.8 to 5.9 for males and females respectively. We recommend that we conduct larger studies to evaluate these findings. We have one underway across 3 centers with 5 times the sample size to begin to validate these findings. And we're advocating that if we validate them, we can advocate for updating our stroke prevention guidelines to integrate ultrasound for stroke risk assessment, and this can save lives. Okay? So, I want to appreciate my supervisors and mentors which I could not have achieved this kind of completed this study. These are my references. Thank you.
Thank you, Dr. Ayodeji. Thank you. Two minutes for questions. We'll start with the assessors. If you have questions for Dr. Ayodeji, but would be appreciative if we have one question from each assessors.
Okay, I will ask a question right away. I'm interested in the renal fat. Do you think that is linked to the renin-angiotensin-aldosterone system?
Yes, sir. In fact, I have a slide on that. Please, can you help me put up? Sorry, can I? Okay. So this finding has been demonstrated in other populations, but not in our population. And it's a recent development, actually. And Xiang et al. In 2024 and others have highlighted the role of perennial fats, disproportionate metabolic impact, and propounded and advanced some theories and as to how this may have been brought about. And some of them are what I've listed here. One is mechanical compression of lymphatics and veins. 2 is release of inflammatory mediators like adiponectin, leptin, TNF-alpha, and interleukin-6. And 3 is hyperactivation of the RAS, the renin-angiotensin-aldosterone system, which can lead to hypertension. And it's been found that there are people that have intractable hypertension because of perennial adiposity. And they've had to do some bariatric surgery to debulk the perineal space for them to be able to control their hypertension. So I agree with you 100%, sir, that it's associated. Thank you, sir.
So do we have questions from the audience before we... You don't have any questions? Okay.
If they don't have, there is somebody from the audience. Oh, yeah. Go ahead, please.
Can someone get the mic to him?
Thank you very much. I'm Dr. Akimbo Ade, consultant ONG, Lagos Island Maternity Hospital. Please, how do we prevent increased perennial fat in the body? That's one. Then number 2, for those who have it, what can they do to eliminate it so as to prevent stroke in most of us that are slim? Thank you.
Thank you very much, sir, for that question, sir. Yes, so how do we prevent it? Okay, so the way it happens is that they've done fat distribution studies and found out that different races and different groups of people have different ways by which they store fat. So when I store fat, some people store them, like we know, some can store them in the subcutaneous compartment. That doesn't generate any risk. In fact, some have said it is protective. And in my study, I found that many people that really were obese, when I went inside, were actually fat and fit. They were fit. They didn't have fat inside. The visceral fat that considered risk was very minimal. And all these people didn't have lipidemia and all those other things, diabetes and all that. There was no metabolic syndrome, but they were fat. But some people store it in the visceral space. And even in the visceral space, some store it more in the visceral fat compartment. That's the deep belly fat. Some store it in the perineal compartment. Some store it in the epicardial compartment. Some store it even in the liver. And that's why we'll talk about fatty liver. So fat can be stored, and this has genetic basis. But there's still a lot of research. It's a very active area of research right now to find out what are the determinants of how people store fat. But what we know is that if we are able to detect it early, and the problem is if you don't detect it early, you just keep doing base BMI, waist circumference, and all that. You may not pick it. But if we use ultrasound as a game changer to detect it early, the same lifestyle management changes, the same dietary compliance would make the fat you need to store less. And what goes to your perineal space will be less. But in extreme cases, like I said, they're about to take drastic measures like doing surgically removing fat from that region. And then it's been helpful. But the other thing we need to note, like I said earlier, is that in this perineal fat thing, the cutoff we saw for stroke rate was just 5 millimeters. That's half a centimeter. So if you use your waist circumference, it may not pick it. So in lean people, of course, this has not been established. It is still something that's still evolving. But once it's validated, we might have to start including ultrasound as part of the routine ways of assessing obesity associated risk. Okay, so I think I've answered the question, sir.
Okay, so just quickly, the last from my end. Can you tell us one potential source of bias in this study? We need to know, because before you draw such conclusions, this is, people, so you have to weigh your options of biases.
Thank you very much, Ma. So there are sources of bias for this study. First, it was a single center study. 2, the sample size was relatively limited. I mean, we had 80, 40 in one group, 40 in the other group. If we do it over population-based studies, we may find something worse than we think it is, and it may be better. And that's why in our own team right now, we already have, in the conceptualization phase, we want to validate this, and we have a multi-center trial involving 3 centers in the southwestern region of the country and 5 times the sample size to potentially validate these findings, and then we can advance this
I think the 2 minutes has gone, but it's good for us to know.
Yes, sir. Which
probe did you use for you did the ultrasound yourself? Which probe did you use, and did you try to correlate this to your stroke by type of stroke? Because if you just a perirenal fat, I didn't tell us whether it's predisposing more to thrombotic, embolic, or hemorrhagic stroke. Because you are trying, because it's very important for the clinician. I think that's a study that you need to look forward to. So which probe did you use, and why did you relate it to the type of stroke? In this
okay, so yes, sir. Thank you very much for the question, sir. So I worked only on ischemic stroke, and I mentioned that maybe because I had to speak very fast. It was on this because we have found out that the obesity thing is more associated with ischemic stroke than hemorrhagic stroke. So that's what we worked on. And props we used, I mean, there are already standard protocols for measurement of this fat. I don't understand probe, sir.
Probe, the ultrasound probe that you use.
Okay, the probe. Okay, sir. So I worked with a General Electric like a P9 machine with okay, so for the perineal fat, I used the curvilinear probe. That's the convex probe. For the visceral fat, I used the curvilinear probe. But I also measured the subcutaneous fat. I used the linear probe for that, sir.
What do you think the curvilinear probe 3.5? Because the penetration. Why didn't you use the linear 7.5?
So the way it works is that the probes we have a range of frequencies. So 3.5 is actually 3.5 to 5. In fact, there are some machines that can take it as high as 6. So we adjust it to be able to, because if we use the linear probe, it may not really show the full extent if the fat depot is actually thick. You may not see it up to the kidneys. So that was why we had to use the curvilinear probe. But because it was a very high resolution machine and we could adjust the frequency, it gave us sufficient
Thank
data.
you very much, contestant 1. Please, let's appreciate him. Excellent work. Thank you. Can we have contestant 2 quickly?
Contestant 2, your time starts now, if the assessors are ready. Please go ahead.
Good morning, panelists, fellow contestants, the audience, Shalina Group. I carried out a study titled Assessment of Cardiovascular Disease Risk Among Adults in Selected Rural and Urban Communities in Rivers State. As we know, cardiovascular diseases affect the heart and the blood vessels with a myriad of risk factors. And these risk factors can be combined to calculate an individual's risk of coming down with a cardiovascular disease. In this study, I used the Framingham risk tool, but there are others that can be used to calculate an individual's risk over 10 years. Other tools can calculate over 20 and over 30 years. In sub-Saharan Africa, it's interesting to note that the age-standardized cardiovascular disease rates in this region is the highest in the world. And that it has been found that in this part of the world, many of our young people come down with cardiovascular diseases even 20 years younger than their counterparts in other parts of the world. In Rivers State, where I conducted this study, studies have found that over 20% of admissions and deaths are responsible for as a result of cardiovascular diseases. So why I wanted to carry out this study, of course, there are established links between hydrocarbon pollution and cardiovascular diseases. So it was important to carry out this study in such a place that is the hub of the hydrocarbon industry in the country. And I also wanted to find out if what is being seen in other parts of the world, in the sense that as urbanization decreases, the risk of cardiovascular diseases increases. That is what is found in other parts of the world. So I wanted to see if this was the case, because some other studies in Africa had already begun to notice this finding. So these were my objectives. I wanted to compare this. And I wanted to also look at it vis-a-vis rural and urban communities to see whether this risk is quite different in both communities. So this encapsulates what I was thinking about. But just to say something about the history here, you find out that many people have contributed to what is known as the cardiovascular disease epidemiology and preventive cardiology. When we hear the word Leonardo da Vinci, we think of a celebrated author. But this person was also involved in identifying that a restriction of blood flow through the arteries is responsible for this diseases, as well as others. In fact, with modern imaging techniques now, they've applied these modern imaging techniques to mummified Egyptians and mummies of Native Americans, and they found evidence of cardiovascular diseases. So the scientific community is wondering, they didn't have these so-called modern lifestyles and processed foods that we have now. So what could have been the risk factors for cardiovascular diseases for people who lived over 4,000, 5,000 years ago? This study was conducted in Rivers State. It was a comparative cross-sectional study among adults in rural and urban communities. And these were my criteria. I used the formula to compare, and I got a sample size of about 610 in each group. I used a design effect as well to improve the precision because of the sampling method I used. So a total of 1,220 participants, and a multi-stage sampling was used. I used a pre-tested structured interviewer-administered questionnaire, and it was collected electronically. So I tested the tool using Cronbach Alpha, gave a score of 0.87, meaning that it tested what it was supposed to test. And these were some of the tools, the statistical tests I used to answer all my objectives. For the results, we can see here that there was the high level of, as in many of my respondents had poor level of knowledge of cardiovascular diseases, although it was not so significant. We see that the prevalence of smoking was higher among the urban and than the rural participants, as well as physical inactivity, although this was not so high because of the different methods to assess physical activity. We also see here that the prevalence of the metabolic risk factors were high, but not significantly different. So we can see that the gaps in the risk factors for cardiovascular diseases appear to be closing. And for the 10-year risks, we can see that more of them had a higher 10-year risks in the rural communities compared to others. So we can see these are the predictors, traditional predictors. For knowledge, of course, it's established that good knowledge will result in low risks of coming down with cardiovascular disease, according to what my study said. So the implications of these findings, we can see with increased smoking, increased risky sexual behaviors, this can predispose to a lot of other conditions.
1 minute left. As
well. Thank you. So let me just focus on, because these are the strengths and limitations. For the uniqueness of this, from the study, I noticed that I can make a cause for us to use these risk prediction tools in everyday settings, and that rural areas are fast catching up to urban areas in the prevalence of cardiovascular disease risk factors. Hence, this has policy implications for health system strengthening. We already know the double burden of disease that's already occurring. So knowledge is also part of the things that we identify. Generally, the level of knowledge was generally poor. Hence, it's a low-hanging fruit. So most of the cardiovascular disease control efforts should focus on health education interventions. Also, large-scale studies should be conducted. We want risk tools that are particular for the Nigerian population. So Shalina Group can think of that, fund large-scale research
Doctor.
around the country. So these are conclusions and some of my recommendations. Thank you very much.
Thank you very much.
Thank you.
Let's appreciate contestant 2. Do we have questions from the audience?
Questions from the audience, please.
1. Okay, go ahead, ma. Please send the mic to her. Hold yours.
Good morning, judges. Good morning, contestants. Good morning, everyone. I'm Dr. Mifta Isolo General Hospital. Thank you very much for your presentation. My question is very simple. What gap do you want to fill by this your study? What is the justification? Thank you.
Okay, thank you for that question. Like I earlier said, in the industrialized world, it is found that as urbanization decreases, the risk factors for cardiovascular diseases and cardiovascular diseases themselves also increases. And then there are pockets of studies in Africa that are already demonstrating this trend. So that was a gap I wanted to fill, to see whether this same trend is what is actually happening in the study area for which I carried out this study. And then also, from from practice generally, I noticed that we are not really promoting the use of these cardiovascular disease tools. And it's something that I wanted to also showcase, use it so that we can, the clinicians can use it, the patients themselves can use it and be involved in their care as well.
Okay, thank you very much. I think you said you did a multi-stage sampling, isn't it?
Yes, sir.
And you compare rural and urban residents.
Yes, sir.
Now, don't you think if you look at Port Harcourt, the rural areas outside Port Harcourt and inside Port Harcourt, a lot of people that you catch in the cities during the time of your study are actually coming from the rural areas to spend the whole of their day for economic pursuit in the cities. So you didn't, there will be a lot of overlap because a lot of them that you catch in the cities during, maybe staying actually in rural areas and vice versa. Don't you think that will compound this your study?
Yes,
because they clearly tell us how you really define the rurality and the urbanity of these two gaps and avoid overlap.
Okay, so at state level, there is a list already of the local governments that constitutes both the urban local governments and then the rural areas. And then also, apart from that, when I was selecting the study, even in rural areas, of course, we have some areas that, have more like semi-urban, so to speak. So in those areas, I wanted to really focus on only those areas that are clearly identified as rural, even in the rural areas, so that my comparisons can be justified.
Okay, so what are potential confounding variables here in this study?
Okay, potential confounding variables, socio-demographic variables. Of course, in my study, I noticed that with increasing age, and that is what is already known. So in the full work, I tried to do some stratified analysis to look at it in age groups to see what these age groups, what the findings will be. So that is part of it. Also, another issue was regarding, and I think that's quite a limitation to this study as well, the incidence of some of these factors too was also part of the things that served as confounders to this study. But to correct this, I did some stratified analysis, I did regression analysis so that, and then in my associations as well, I also included variables that, despite the fact on bivariate analysis, that they were not significant at bivariate analysis. But in literature, they have been identified with cardiovascular diseases, the incidence of cardiovascular diseases. I also included them into the model. And at bivariate analysis, I took my level of significance even higher to also capture that, so that all variables that have been known from literature were included into the final regression model that was used.
Thank you very much.
Thank
Excellent.
you.
Please, let's appreciate contestant.
Thank you very much.
Thank you. Contestant 3, please. Get set.
Can we give a round of applause to contestant number 3 as he walks off the stage? So contestant number 3, your time starts now as long as the assessors are ready.
Good morning, assessors. Good morning, audience. Good morning, everyone. I'm Dr. Mustafa presenting on the relation of ultrasound estimated fetal weight with actual birth weight at Federal Teaching Hospital, Katsina. Actual birth weight is the first weight of an infant obtained immediately at delivery, while estimated fetal weight is obtained in utero using any of the recognized fetal weight estimation formula that uses one or more fetal biometric parameters measured at ultrasound. Some of these parameters include the parameters measured bioparental diameter, BPD, head circumference, HC, abdominal circumference, AC, and femoral length, FL. ADLOG 2 combines BPD, AC, FL, ADLOG 3, HC, AC, FL, while ADLOG 4 combines all the 4 parameters. Nigeria has high perinatal and maternal morbidity and mortality. So improved accuracy of estimating fetal weight will help to improve this indice because clinicians will be able to preempt and prevent possible unavoidable complications at delivery. Most of these formulae were derived from Western population and has not been validated in Nigeria. And some of the Nigerian studies that have done this have shown that varying locations have varying formulas that are best in those locations. There's hence the need for the study. So I'm here to I did the study to compare the weights by these three formula, log 2, 3, and 4, with the actual birth weight. I want to also check the formula with the least error, then effects of factors like fetal sex, maternal BMI, and AFI on the accuracy of fetal weight estimation. Excerpts from my literature research review is just to show that of the various methods of fetal weight estimation, ultrasound fits the, it has the potential, it is good in terms of accuracy, availability, and safety. This is just showing some other studies that have been done in Nigeria about the case, and they had various results. The prospective study that was done in labor room among women who had TAM, who presented in latest phase of labor or presented for elective CS or induction of labor. So patients who are unsure of the LMP, who refuse to partake in the study, patients with congenital anomaly in their babies, serious maternal medical condition, and delivery after 72 hours of ultrasound estimation were excluded from the study. The appropriate statistical formula was used, and its minimum sample size of 300. The sample size of 300 was used after addition of 10% to cover for attrition. The systematic sampling method was used to select each participant. A data profile was used, and the maternal age, gestational age, BMI, estimated fetal weight using a log 2, 3, and 4, fetal sex, AFI, the baby weight after delivery were all documented, and statistical analysis was done using SPSS. For improved accuracy, each of the fetal biometric parameters were measured 3 times, and the average value was used to calculate the formula. The standardized digital weighing scale was used, and the midwife measuring the baby weight is unaware of the estimated fetal weight to reduce bias. Then, of course, I had ethical clearance from both the college and my center. This the ultrasound machine used the weighing scale and the digital weighing scale that was used. So the result, this shows the demographic characteristics of my respondent, and most of the babies is slightly more male babies than female babies. So this table shows the correlation coefficient of both the 3 formulas. That as you can see, log 3 and log 4 are similar correlation coefficient, slightly better than log 2, which is just 0.73. Then also important is the comparing the means by the 3 formula. Log 3 is the only formula whose means is not statistically different from the actual birth weight, where the other 2 formulas are statistically different. Also, the error indices I measured include the mean percentage error and mean absolute percentage error. For these, you can see that log 3 has the lowest, which is statistically different from that of log 2. Then log 4 was in between. Also, the proportion of estimates within 10% of actual birth weight for log 3 is slightly higher. It's higher than the remaining formulas. So, and also, when I checked those factors, I found that fetal sex, maternal BMI, have no significant effect on accuracies of fetal weight estimation, while pregnancy is complicated by oligohydramnios significantly affects the accuracy of fetal weight. So the findings from this study are similar to those that have been done in various studies in Nigeria and some sub-Saharan Africa, showing that log 3 has been shown to be good in many locations. In fact, currently, the British Medical Association recommends the use of log 3 for fetal weight estimation. So uniqueness, easy and immediate implementation of findings from the study. My center now used log 3. Number 2 is there's less feedback for weight discrepancy are significantly reduced. There's a need for larger population study to further strengthen the effects of AFI on fetal weight estimation. So I concluded that log 3 is the best to be used on study convolution, and oligohydramnios negatively affect fetal weight estimation. Log 3 should be used as recommendation. Log 4 can be used when log 3 is not available. Log 2 should be discouraged. Then there's a need. Then the pregnancy complicated by oligohydramnios. We can use other methods to confirm what we have gotten. Limitation, limited to only 3 formulas which are present on the ultrasound machine, so that the findings from the study can be really close into practical use. Number of patients with oligohydramnios are few, or statistical analysis was possible. These are my conclusions. These are my references, and some of my references.
Thank you, contestants. Thank you. Thank you. Questions?
Questions, please. From the audience, 1. Okay, Ma, go ahead. Mike?
Thank you very much for that good presentation. My question, please, can you just run through what makes up Hadlock 3, 2, and 4, the measurement parameters, please? Thank you.
So that was the introductory, the first slide. For Hadlock 2, I'm measuring BPD. This is it. For Hadlock 2, I'm measuring the BPD, AC, and FL. Hadlock 3, I'm measuring HC, AC, and FL. While Hadlock 4 combines all the 4 parameters, BPD, HC, AC, and FL. Thank you very much.
Okay, do we have more questions?
How does the gestational age of the fetus affect your measurement using any of these formulas?
So it was not, because it was not part of the study objective. That's why I did not measure it. I did not mention it. Sorry. So, but it does not have any significant effects on the accuracy of fetal weight estimation. That's the gestational age. Because at term, the babies, some are less, because I grouped them into 2. Those that were delivered before term, that's before the dates. I used both post dates and before date. That's the term pregnancy is from 38 completed weeks. That's 37 completed weeks to 41 completed. That's 38 weeks to 42 weeks. Those are the patients I'm using. So those that deliver before 40 weeks and those that deliver after 40 weeks. That's how I graded them. And I found that there's no significant difference between the gestation, the weight estimation based on that's the time of delivery. Thank you very much.
I'm asking if you're checking for preterm delivery and you want to estimate the weight before delivery, how will this accurately predict that? Because you are only looking at term pregnancy. So is it something you discouraged if, we are going to look at preterm deliveries and pregnancies?
Okay, sir. Yes, one of the most important determinants of low birth weight is preterm delivery. Majority of babies that delivered preterm have low birth weight. I have, yes, sir, it's important. I have 10 of my patients. Yes, 10 of my patients have low birth weight. So I use that. Actually, in studying this, initially I wanted to do late pregnancy, but I'll cover before term and at term. But the fact that late pregnancy is a vague terminology, and in studies we need to use a terminology that is not vague. That's why I've been advised that it's better I use a term pregnancy that is more accurate. And also, for further studies in the future, we'll also try to look at those patients that are preterm. Then across board, as I've mentioned now, bearing weight of babies, the accuracy is the same across board. Thank you very much.
Just one comment from me. What was the gold standard? Because before you can say this is accurate, there must be comparison with a gold standard. And their gold standard will give you near perfect, results. So did you have a gold standard or you just compare the 3 without, because for you to say this is excellent, the sensitivity of that instrument, the sensitivity of that method should be assessed. So was there a gold standard?
Yeah. Thank you very much, ma'am. Thank you. Yes. The gold standard is the actual birth weight. The actual birth weight is the weight of the baby. We are sure this is their weight. We now went to check the weights by Hadlock 2, 3, and 4. Which of them is closest to the actual birth weight? Of course, that's how we got that Hadlock 3 was one that is closest and not significantly different from the actual birth weight. Thank you very much.
What was the sensitivity?
Sensitivity?
Did you do that? Or did you do the ROC code? What was it?
Yes. Sensitivity was around 70%.
You are sure it's 70% because that would be.
I can't really. I can't remember.
Okay. Thank you for your excellent work.
Thank you. A round of applause for contestant 3. Contestant 4. Are the assessors ready? Okay, contestants number 4, your time starts now.
Right. Good morning, assessors, members of the audience, fellow contestants. So I did a little study on assessing the use of cardiac troponin 9 to assess possibility of patients coming down with cardiotoxicity while receiving anthracycline-based chemotherapy. Breast cancer management has changed over the last few decades, and use of chemotherapy is still being advocated. However, toxicity has always remained an issue. Anthracyclines have always been a bedrock for cancer chemotherapy, especially in breast cancer. However, its extended use has led to cardiotoxicity. The essence of this study is to find out how we can make it safe for patients to use, even in extended states. Ordinarily or traditionally, the use of 2D echocardiography to measure left ventricular ejection fraction has been the standard, but this has been shown to be less effective, especially less than 3 months. However, highly active or highly sensitive cardiac troponin 1 has been shown to pick up changes in myocardial injury in less than that period. So the objectives is to assess the possibility of the use of cardiac troponin 1 as a standard biomarker for assessing cardiac risk in patients receiving anthracycline-based chemotherapy, and also to assess this risk in the most popular anthracyclines that are available in the market, and also to look at various variations of troponin levels during anthracycline based on individual variables. So these are the eligibility criteria: ages 18 to 70, all stages of disease. However, an ejection fraction of greater than 55 must have been met, and also patients must have a performance status of at least ECOG 2. So this work was done as a descriptive cross-observational study prospectively in Department of Radiotherapy at Lagos University Teaching Hospital. We used blood samples collected from patients 4 hours after the administration of chemotherapy over a period of 6 months, 4 cycles. And we also measured the left ventricular ejection fraction before the commencement of chemotherapy and at the end of chemotherapy after 6 months. All patients had histologically confirmed breast cancer. Sample size was 115, which included case controls. Enrollees were selected using randomized sampling technique, and informed consent was gotten from all patients because we use a data extraction sheet to get the bioinformation from these patients. Results were analyzed, and data was presented as proportions and frequency tables for categorical variables, and comparison of findings were done with a chi-square. So basically, the results show that there was marked significant increase in the dramycin arm of patients receiving anthracycline, and this increase coincides with subclinical myocardial tissue injury. We all know that once there's a cutoff of 0.14 nanogram per liter, once that point has been exceeded, cardiac troponin 1, the levels would increase, and that will signify possible subclinical myocardial injury. Also, we've noticed that for patients that are hypertensive, diabetic, that these values are much higher. So we can actually use this tool to predict patients that will suffer possible myocardial injury while on anthracyclines. Also, we compared this study with the ages of patients. So the higher the age of the patient, the higher the risk of increased level of serum cardiac troponin 1. Then we compared the values of cardiac troponin 1 against that of left ventricular ejection fraction, and you could see clearly that though there were some mild changes with the left ventricular fraction, but they were insignificant compared to those of cardiac troponin 1, which increased significantly pre-chemotherapy, mid-chemotherapy, and post-chemotherapy. So limitations of this, limitations and strengths. This was the first prospective research to look at the use of cardiac troponin 1 as a possible biomarker. Sample size selection was adequate to reduce confounders. However, this study did not identify patients that eventually developed cardiomyopathies due to the short follow-up period, which was just 6 months. So in conclusion, cardiac troponin 1 can be used for patients as a assessing tool to pick up possibility of cardiomyopathy even at the subclinical level. Recommendations, just like I said, it can be used as oncologists for assessing the risk of cardiotoxicity, patients receiving anthracyclines. This is especially important because of the relative, the costing of this test is relatively cheap and it can be readily available to patients. However, for possible studies, large sample size has been advocated. So these are my references. Thank you.
Thank you, contestants 4.
Questions, comments? Okay. Is there someone in the audience who wants to ask?
Before somebody decides, why did you go for only the left ventricular ejection fraction? Why didn't you do ECG on these patients? And why the 4 hours post-chemo session? Why not 6 hours? Why not 1 hour after? What made you choose 4 hours after each session of chemotherapy? And why did you go for ECG, which is simply could do to correlate with it? Thank you.
Okay. Thank you for that question, sir. So, as a standard in oncology, we would normally refer to the use of left ventricular ejection fractions for patients that are receiving anthracycline-based chemotherapy combinations. So, once you have a level that is below 55%, that patient is not considered fit to receive anthracycline-based chemotherapy. So that was why we used left ventricular ejection fraction. Subclinical myocardial or cardiac injury happens 4 to 6 hours post-administration of anthracycline-based chemotherapy. If we had taken the sample 1 hour before, we would probably have a value that is not reflectant of what we are supposed to find. So we normally would wait at least 4 hours to take that sample.
So if you had taken 6 hours, probably would have gotten a different value too.
4 to 6 hours is the cutoff.
So what made you to choose 4 hours?
I would say it was picked up from patients at an outpatient clinic. So 4 hours was what we felt was good enough to take samples from this patient. 6 hours, I don't think would have made any difference. There are studies that have shown that between 4 to 6 hours, the rates are still the same. The values rather are still the same.
Probably will have come out with something different in our own population.
Yes, most possible.
Thank you. Do we have questions from the audience? No question.
Let me just ask, what exactly is the mechanism of injury from anthracycline?
Okay, anthracyclines, what they do is they poison the DNA and cause DNA damage and poison the topoisomerase bridges. So that's how they cause damage to cells. And they do...
They also affect conduction, apart from the myocardium. They affect the cardiac conduction itself rather than myocardium.
Well, it's supposed to if it can affect. Because yes.
That is important in line
yes.
with the ECG
yes.
he mentioned. Because what you're just looking at the structural.
Yes, the target was structural damage, not functional damage.
Not functional damage. So you may have had conduction defect, conduction damage long before structural damage, which you didn't look at.
No, this was just basically to look at functional damage, or structural damage rather.
Okay, and I hope you know there are ethical implications of that. You know, while waiting for the patient to develop, some things are going on, and you as a physician or a doctor should be able to.
That's why, as part of this work, at the end of completing the chemotherapy, patient had a post-left ventricular fraction also done. So there was follow-up for these patients as well.
Okay, just some comments from me. Your study design, what was it really? The study design you used?
Prospective observational.
What type of observation?
Prospective descriptive study. Descriptive observational study.
Okay.
Yes.
Because we rarely use the term, that prospective, I see it a lot, but
okay, so it's a descriptive.
phased out. Okay, so if you're doing a cross-sectional study, yes, you're doing a cross-sectional descriptive analytical study.
Okay.
And then I saw randomized sampling.
In picking the patients, ma'am.
Yes. So randomization is a different ballgame entirely. So you're using that for experiments and things like that where you want to select. Okay, so not for a cross-sectional study.
Okay, we use that we didn't want to.
How did you do the randomized sampling? How did you perform that?
Okay, for every patient that had histological confirmed breast cancer that came to the clinic, we picked every odd number that came to a clinic day. So that was what we did.
Okay.
This is not randomized. If you just decided to use odd, you can
numbers also. Yes. So we just decided to use odd. We could also have been even.
I think it's a modified convenience by yourself.
Okay.
It's not randomized, please.
Okay.
Okay, thank you very much.
All right, ma'am. Thank you.
Thank you, contestant 4. A round of applause as contestant 5 takes the stage. Assessors, are we ready? Okay, your time starts now, contestant 5.
Okay, thank you very much. Good afternoon, panel of judges and the audience. The title of my dissertation is Skin Wound Closure Outcome Using Tissue Adhesive as Subcorticular Sutures at Elective Cesarean Section, University College Hospital, Ibadan, a randomized control trial. And in making this presentation, I declare no conflict of interest. And I'll be following this outline. Skin wound closure is a very important aspect of cesarean section as it significantly affects the patient's postoperative pain perception, rate of wound healing, the rate of wound complications, as well as the cosmetic outcome and the patient's satisfaction. And as we know that cesarean section involves a mother-baby pair, and the rate of complications and also postoperative pain should significantly be reduced to the barest minimum in order to ensure their comfort. And over the years, various skin wound closure techniques have been applied, ranging from sutures to the staples, the adhesive tapes, and more recently, the tissue adhesive, which is also known as tissue glue. However, there is no definite evidence regarding the ideal method for skin wound closure at cesarean section. And because most of the previous studies that have been done significantly excluded the obstetric population. And more importantly, when I searched the literature during my literature search, I found no study that involved the black population. And the black population has significant skin characteristics that were different from the Caucasian populations, which were included in most of the obstetric populations in the previous studies. And so we aimed to determine to compare the use of tissue adhesive with subcortical absorbable sutures at skin wound closure and determine the patient's satisfaction and cosmetic outcome of each technique using the patient's satisfaction scale and the patient and observer scar assessment scale by the patient and an independent blinded observer who was a plastic surgeon at discharge and at 6-week postpone. And we specifically determine the cosmetic outcome, the rate and type of wound complications, the patient's satisfaction, and then we also provided recommendations regarding superior skin closure techniques. The study was a 2-arm, single-blinded superiority randomized control trial in which women who had elective cesarean section met the inclusion criteria were recruited. The participants were randomized into 2 groups. The intervention group had the skin wound closure using dermabrasion tissue adhesive, while those in the control group had skin wound closure using Vicary 2O sutures. A total of 214 women were assessed for eligibility. However, 192 participants met the inclusion criteria and were randomized into each of 96 in each arm of the study. These were the eligibility criteria we used in the study. So at the end, the study outcomes were compared using the independent student test, which is correction, as well as chi-square test for normally distributed data and man-whitening test for the school data. The analysis was done using the IBM SPSS for Windows version 23. And this was the consult flow diagram chart we used in the study. As you can see, the 22 participants were excluded with the reasons as highlighted on the table. So at the end, we had 92 participants who completed the study in the tissue adhesive group and were analyzed. While in the subcortical suture, we had a total of 93 participants. And so we used the per protocol analysis model for analysis. A total of 185 participants completed the study, and the participant characteristics were noted in the study to be similar in both groups. The participant assessment of the cosmetic outcome of their surgical wound was noted to be significantly better for the tissue adhesive group. However, there was no significant difference when assessed by the independent blinded observer study. And this table highlights some of the differences in their observations. Also, there was no significant difference in the patient's satisfaction with their scar, but the need for additional analgesia in the first 24 hours after surgery and the duration of skin wound closure was significantly lower in the tissue adhesive group. Also, there was no significant difference in the rates of wound complications, as you see in the extracts from the tables and the highlights. The main findings from the study were that the cosmetic outcome of the wound closure using patient and observer scar assessment scale and the patient's satisfaction scale were not significantly different between the two groups of the study, although the need for additional analgesia and the duration of skin wound closure was less in the tissue adhesive group. And there was no difference in the incidence of and type of wound complications. So the strength of the study was the fact that we had an effective abnormalization as evidence in the similarity in the patient's characteristics. And then the independent blinded observer also helped to reduce the risk of bias in this observation bias. And the study was not without limitations as listed. The conclusion from the study was that the cosmetic outcome and the patient satisfaction is not superior to the use of subcortical suture when we compared with the tissue adhesive. Although the patient's pain control and the rate, the speed of skin wound closure was significantly better with the tissue adhesives. And so it remains an option, especially when the rate of less need for analgesia and the lesser risk of needle stick injury and the ease of application is considered advantage. Also, when considered the risk of wound infection, it could also be used in other future studies, and the cost and time savings in future studies could also be considered as superiority in this regard. So these are some of the.
Thank you. Thank you. Thank you.
Thank you.
Please a round of applause for him. Do we have questions? One. Go ahead, microphone.
I wanted to ask, I had in mind of asking about pictures. I think that was the last thing I said. So the pictures, please. So which ones have the subcortical adhesive and which ones are for the vacuum? Thank you.
Much more for that observation. This was for the tissue adhesive. That was on the first day after surgery. And this was the appearance at 6 weeks post-op when they came for follow-up. While this was for the subcortical suture, and then this was the appearance at 6 weeks after surgery. And this were some of, this was when I was training my other colleagues on the application. And then, thank you very much.
You see, how did you, because did you do the cesarean section for all these, your colleagues did some of them?
No, sir, we had 3 senior registrars who were...
So how do you correct for the surgical skill and expertise of the person doing the cesarean section vis-a-vis applying the adhesive tape and the subcuticular suture? Because how surgeon A will do is different from surgeon 2. That will compound your findings, and you're assessing pain and healing. Somebody that you put a suture at a tape, from the beginning you know that it's going to be more in the other group. So how do you correct for that, please? Thank you.
Thank you very much, sir, for that question. So now, before this, we began the study. We had 3 senior registrars who were going to be having their postings in the labor ward during that period. And the senior registrars on posting during in the labor ward was the one in charge of the cesarean sections that were conducted during the period of their posting. So what I did was I was one of the senior registrars who were going to be undergoing my postings at that time, and my other colleagues who were going to be in their posting at the time of conducting the study. So what we interestingly, we were at the same level of training based on the fact that we passed our actual examination at the same time. So it helped us and we were just 3 during the course of the study. So we were all trained on how to apply it, and then so it helped us to reduce the surgeon differences that we could have had during the course of the study.
Okay, thank you. I'd just like to know, as a methodology expert, how did you do what type of blinding? Because and then your randomization. When you talk about randomization, everybody's ear pops up. So how did you ensure that the groups were comparable and the randomization was done properly? So I want to know your process of randomizing your participants. I was expecting to hear words like allocation, concealment, things like that when you're doing randomization. Okay?
All right. Thank you very much, Ma, for the question. Because of the constraint of time, I couldn't project most of this. So now, the randomization I did was a blocked randomization. So it helped me to ensure that there are the blocks of the participants who have at each time was the same in each block. So I had a block of blocks of 4 during the study, and so that was the method of randomization I used. Now, regarding the allocation concealment, what I did was to number or pick envelopes, which from 1 to 196, and then each of the number that the blocks gave me, I put in each of the pick envelope and pick them serially as I recruited the patients to put them in each of the groups we had in each of the arms, or in each of either of the 2 arms that we have had in the study.
Okay.
Would it have been better, since you know your sample size, use a computer-based and generate random numbers?
Yes, sir, that was what I did, sir.
So that's what, yeah.
That was what I did. But the computer-generated random numbers was blocked randomization I did.
Okay, so what type of blinding? How many stages of blinding did you do?
Yes, sir. Yes, ma'am. So thank you very much for that question. I did a single-blinded randomized control trial.
At what point of your study? At what level?
Okay, ma'am. It was at the 6 weeks assessment, and the only person that was blinded in the study was the plastic surgeon, who was the only blinded person in the study. And the reason was that we could not achieve blinding for the patients. And so the only person that could have helped us to increase objectivity was the plastic surgeon, who reviewed this wound at 6 weeks. And so to also ensure that he was properly blinded, we had high-resolution photography of the wound at constant distance, at 60 centimeter distance, which was taken, and those were part of the pictures that I projected on the slides.
So don't you think you should have blinded earlier?
There was no way I would have been able to blind earlier, because the methods for application and care of the wound for each of the groups was significantly different.
Okay. Thank you, contestant 5.
Thank you, ma'am.
Thank you.
Let me just ask a question before you go. Yeah, one of the most important things which you didn't look at is the costing. And you say you didn't look at it. So the one then wonder, what is the essence of all this if you do not know how much more or how much less it's going to cost? And the other thing you also didn't say fully is the time. How much time did you really gain by using this method rather than this subcutaneous tissue? Is that time really worth all the effort?
All right, sir. Thank you very much, sir, for the question. So we actually gained double the time that for the skin wound closure, double the time for the half the time rather for the tissue adhesive group compared to. So in total we had an average of 3 minutes to close the wound using the tissue adhesives, while we had an average of 6 minutes to close the wound using the. 3 minutes. Yes, sir.
Okay. So the question is wondering, is 3 minutes worth it? Then what is the cost of gaining 3 minutes in terms of costing? You didn't tell us.
Yes, sir. So regarding the costing, apparently I started the study before I got to know about costs analysis. So, so what I did was a simple cost comparison, which will not be sufficient. And that was part of my limitations, that it would have been better to do a cost analysis to be able to determine if really it was worth it, the time that we saved. And other advantages were worth it to use tissue adhesive above subcortical sutures.
Thank you.
Thank you very much.
Let's appreciate him. Thank you, contestant 5.
All right. Thank you so much. Thank you, assessors. Thank you, our finalists. Thank you very much. At this junction, we're halfway done, and I want to quickly recognize one or two special guests amongst us, even though I've been advised that everyone is special. Thank you all. First, let me call on and recognize the presence of our Head of Sales and Marketing Institution, Dr. Kiran Prakash. Please, you're welcome, sir. Thank you. All right. Then we have the representative of the Nigerian Medical Association, right? The president of the national president of the Nigerian Medical Association, who is ably represented by the first vice president, Dr. Benjamin Oluwojebutu. You're welcome, sir. Thank you, sir. Also with us is Dr. Olaoye. Dr. Olaoye, thank you for coming, sir. I appreciate. Right. Professor Chris Aimaku from UCH, ONG, consultant ONG UCH. You're welcome, sir. He's also a friend of the house. Right. S.A. Jenny Iyofu, permit me, is of Research Department, FMC, Ebutemeta. Please, you're welcome. Welcome, ma. Thank you. Dr. Akimboade Francis, Ademola, ONG, Lagos Island Maternity, a very constant star, a friend of the house. Welcome, sir. Nice to see you again. Thank you, sir. Dr. Ayolua Osha, permit me, I can't see the Senior Registrar Family Medicine, FMC, Ebutemeta. Please, you know yourself, we appreciate you. Thank you. Thank you. Dr. Kadiri AA, Medical Officer, St. Leo Medical Center. Thank you for coming. Thank you for coming. Dr. Oshikoya MA, HOD GOPD General Hospital Ikorodu. Thank you, sir. Nice seeing you, sir. Thank you very much. Dr. Ekong Winnie Willie, MOGOPD Ajeromi General Hospital Ajegunle. Thank you for coming. Right. Next is Dr. Shinowo Bolanle, Community Health General Hospital Ijede. It's Solo rather. Sorry, nice. Thank you for coming. Thank you. Sorry. Dr. Aramide Adediron is a consultant endocrinologist, General Hospital Ifako-Jai. Thank you. Nice seeing you, man. Thank you, man. Dr. Stella Alagba, HOD Nephrology, General Hospital Lagos. Thank you for coming, man. Thank you, man. Dr. Jami Bolaji AY, ONG FMC Ebutemeta. Thank you for coming. I appreciate you, man. Justus Mercy, Anesthetics Federal Medical Center, Ebutemeta. Thank you for coming. I appreciate you. Oziegbe Ogide, Family Medicine Lut. Nice to see you, sir. Thank you, sir. Yes, sir. Adeniyi, that's prescription writing now. GOPD A and E, Ajeromi General Hospital. Nice seeing you. Thank you very much. Thank you very much. Pardon me. Okay. Olayinka Sherif, Family Medicine, NMA. Okay, NMA representative. Thank you. Nice seeing you, sir. Thank you very much. Adewonyi Adeolu Adeniyi, Federal Medical, Family Medicine, OAU, this is long. Adewonyi Adeniyi, please, can we see you, sir? All right, he just went. I know he came all the way from Ibadan. Right, I think IAR&T. Right, Ibadan. Thank you, sir. Dr. Shotubo Shoyinka, physician, first at PHC, Amuwo Odofi. Thank you very much. I appreciate you. All right. Dr. Olawale, Family Medicine, General Hospital Ifako-Jai. Thank you, sir. Nice seeing you. Dr. Mrs. Oyeni Ikeja, consultant family medicine, GH Lagos. Odo. Thank you, ma. Nice sitting you. Dr. Mifta Safia, HOD family medicine, General Swiss Solo. Thank you. Thank you for coming. Right. As they come, we also recognize them. At this juncture, let me also mention that we'll also be seeking the permission and the go-ahead of the finalists. What we normally do, Shalina is in about 21 countries in Africa, still counting. And most of these case studies, most of the dissertation, we also share. We make into a booklet. We share, right, with other operating units in Africa. So after the program, we also seek the advice, your go-ahead, if we can also make this into our normal booklet, share with other OUs, share with other countries, so I can gain from this wealth of experiences you have. I will be reaching out to you to get your buy-in and go ahead for doing that. Also, please, we also recognize the presence of Dr. Mafeso Tolulokwe Esther, family medicine consultant, General Hospital Lagos. Thank you for coming, man. We appreciate you. Thank you. So, I guess at this juncture, we'll just take 2 minutes of interlude. Media, 2 minutes interlude before we call on the 6th presenter. Thank you. I hope we are enjoying it so far. I hope we're enjoying ourselves. So I'm sure we're taking notes and gaining 1 or 2 things. I'm persuaded about that. Media, please.
As a mother, I'm always ready to keep my family safe and healthy.
Mom, we won the match.
I'm proud of you, son. Well done.
Thank you, Mom.
It's time to fight the germs.
Jamo soap?
Hey there, little hero.
With Jamo?
Want a football match?
Yes.
Now it's time to win against germs with Jamo Shower.
Jamo, it's all in one. Care and protection till the job is done. Jamo.
You are a woman of mystery, brushed with beauty. You are a woman of enigma, layered with personality. You are a woman of elegance, painted with desire. Presenting Mona Lisa, a new range of moisturizing lotions and creams enriched with the finest ingredients for 48-hour moisturization. For women who are art, for women who are beauty. New Mona Lisa. Come discover the art of beauty.
The world of boxing is in shock. The highly acclaimed champion, Mr. Three Blows, has fallen ill. Mr. Three Blows is experiencing malaria symptoms. Will he be able to deliver the knockout performance we've come to expect? Will he be forced to withdraw?
Mr. Three Blows, you know how much I don't bet for it? I got stand up with you. Oh yeah, take. Make use and sharp. Anthem, you too sure.
Masters, we love
Mr. Three Blows and his fans celebrate victory thanks to Shalatem anti-malarial drug.
Shalatem, which contains artemether and lumefantrine, knocks out malaria in 3 days. If symptoms persist, consult your doctor.
It's another day to get out there. Head out for sustenance. Work for the future. Life can be good or painful. For those painful periods, you always have a partner to count on. Ibucap is always with you, giving you the desired relief from pain. Ibucap capsule, always with you to beat pain. Marketed by Shalina Healthcare Limited.
The world of boxing is in shock. The highly acclaimed champion, Mr. Three Blows, has fallen ill.
You know how much I don't bet for it? I got stand up with you. Oh yeah, take. Anthem, you too sure.
Three Blows and his fans celebrate victory thanks to Shalatem anti-malarial drug.
Shalatem knocks out malaria in 3 days.
Is there anything you want to say to me?
So, take Salto.
It has the power of 5 natural active ingredients that clears your throat when you need it the most. Shout to get your voice back.
My tutu, I don't want to live without you, tutu. Will you marry me?
Think natural. Think Shout to.
Shout to Los Angeles.
Just for you. I ate so much fried and spicy food at the lunch today. Right now I'm having heartburn and indigestion.
Say yes to Polygel Dual and no to heartburn and indigestion. Polygel Dual provides double action and rapid relief. It neutralizes excess stomach acid, stops acid rise by forming a protective layer, starts working in 25 seconds, and the effect lasts for more than 3.5 hours. Polygel Dual help you maximize every moment.
Your Honor, my client is not guilty.
Then let him say that he is not guilty.
Sir, I'm guilty. Section 2.
It has the power of 5 natural active ingredients that clears your throat when you need it the most. Shout to get your voice back.
No, Your Honor, I am not guilty.
Then you are free to go.
Think natural. Think Shout to.
Don't worry, sir. It's a simple procedure, okay?
Give me this cup.
No.
Give me this cup.
Okay, take Shout to me.
It has the power of 5 natural active ingredients that clears your throat when you need it the most. Shout to get your voice back.
Procedure successful. Think natural. Think Shout to.
Shout to Los Angeles.
Mom, Dad, it's time to get up and brush your teeth.
Oh, I don't want to brush my teeth.
But it's not just any toothpaste, it's Frodent.
Oh, the one with the ingredients that gives strong white teeth?
Uh-huh.
The one with mint for all day freshness?
Uh-huh.
Well, in that case, we will happily brush our teeth.
Packed with the long-lasting freshness of mint. For fresh breath every day, Flodent toothpaste. Your kids will love it and you will too. Flodent. Grab life, grab the freshness.
This is the title of my dissertation: Predictors isolate an antibiotic sensitivity pattern of acute bacterial meningitis among children presenting with fever and convulsion, Federal Medical Center, BIDA. Acute bacterial meningitis is a devastating illness. It's one of the leading causes of under 5 mortalities in Nigeria currently. Those who survive the disease have devastating sequelae: hearing loss, cerebral palsy, mental retardation. It's a disease no child should have, no one should have it. Now, it presents with fever and convulsion, but there are other illnesses like even respiratory tract infection, urinary tract infection that can present with fever and convulsion, and there's a risk of missing diagnosis. The World Health Organization aims to defeat this disease by 2030. All right. Many documentations on acute bacterial meningitis in that region has been over 20 years, and that was done by Odedino et al. In 2001, where she discovered that Neisseria meningitis was the highest cause of acute bacterial meningitis in children in the region in Bida, North Central Nigeria. Now, however, there's been documentations about the changing trends of diseases over the years due to climate change, advancing technology, urbanization, just to mention a few. Now, when those studies were done, then vaccination against some of the key agents causing bacterial meningitis in regions had not been introduced. So that gives a point that there might have been a disease change, a disease pattern change in acute bacterial meningitis in Bida. Now, it became expedient to understand the pattern of acute bacterial meningitis currently to be able to achieve the WHO goal of defeating meningitis in that region. And that information will guide appropriate actions to combat disease in that environment. We study aimed to, amongst children between 1 age to 14 years, who present with fever and convulsion at Federal Medical Center to determine the prevalence of bacterial meningitis in that age group. What organisms are isolated are causing bacterial meningitis in that age group. Then the antibiotic sensitivity pattern of those isolated organisms. Then if we could look at the clinical predictors, determine those factors that you can see. A child who comes with fever and convulsion, you should likely think of meningitis in them if you see those features. So we looked at that. It was done over a 12-month period following ethical approval. It was a descriptive cross-sectional study. Now, using a prevalence of 6.9% by a study done by Madhu et al. In 2012 from Zaria, we determined a sample size of 110 for which 2 participants were recruited consecutively at an average of 2 per week over the period of the study. Those who were excluded were those who had contraindications to lumbar puncture from the study. Now, we had a semi-structured proforma that used to document variables, clinical variables of such patients. We also took cerebrospinal fluid samples to determine the protein level, the glucose level, the microscopic culture and antibiotic sensitivity pattern in those individuals. All right, we had the diagnosis of acute bacterial meningitis was those who had positive gram stain or who had culture proven, who had organisms grown on the cerebrospinal fluid culture. Now, the results showed that out of the 110 participants, 7 of them had culture-proven acute bacterial meningitis, right? And the commonest organism causing bacterial meningitis in that age group was Streptococcus pneumoniae, 5 out of 7, while 1 each for Staphylococcus aureus and Listeria monocytogenes. Now, the Streptococcus pneumoniae isolate was 80% were sensitive. All were sensitive. They were all sensitive to cefotaxime and rifampicin. While 4 of them were sensitive to ceftriaxone, penicillin, meropenem, clindamycin, and vancomycin. While only 2 were sensitive to chloramphenicol. The Staph aureus isolate was sensitive to the 3rd generational cephalosporins, the ciprofloxacin, penicillin, clindamycin, and vancomycin. While it was resistant to chloramphenicol, gentamicin, and rifampicin. Now, Listeria monocytogenes was sensitive to the known agents, ampicillin, meropenem, sulfamethoxazole, trimethoprim, and penicillin. Now, looking at the predictors, out of about 21 variables that we looked at, we found out that the factors that were significantly associated with those that had acute bacterial meningitis were these 6 of them. Now, that's the age of the patient, the vaccination status, the signs of meningeal irritation, level of consciousness of the patient, bulging fontanelle, and deep tendon reflexes. However, we further had to do a motivated analysis to determine which of those 6 were actually predictive of acute bacterial meningitis. And this was age, less than 12 months, those that did not have vaccines, and those that had signs of meningeal irritation. These were the 3 clinical factors that were predictive independently of acute bacterial meningitis. Now, the prevalence compared with other studies that have been done previously, okay, and it was far lower than what was discovered in 2001 by Odedino et al. And the predictors most studies had determined lower age group and vaccination status and signs of meningeal irritation as a predictor, but most had not documented vaccination, which was positive in this study. All right, this showed the current pattern of acute bacterial meningitis in Bida. What we had known was Neisseria meningitis being the commonest cause of acute bacterial meningitis in Federal Medical Center Bida, but now we've seen that it's Streptococcus pneumoniae. And this corroborated the changing trends of the epidemiology of acute bacterial meningitis, like other disease conditions seen. It would be good to use a molecular study to look at what serotypes of strep pneumo actually is causing bacterial meningitis in this region. So it's concluded that APM is still significant in Bida, and any child who is less than 12 who lacks vaccination and has meningeal irritation should be thought of having bacterial meningitis.
Thank you. Thank you, contestant 6. A round of applause for him.
Thank you, contestant 6. We'll now entertain questions, comments, feedback from the audience. Okay, go ahead, sir. Please, can you get the microphone too?
Thank you for the presentation. It was really lovely. And I'm Chris, okay. I just want to ask, in terms of the sensitivities, were there any restrictions in terms of the antimicrobial sensitivity in terms of your labs? Because if there are restrictions in terms of sensitivity to the antibiotics, you may not be able to pick other ones that they are sensitive to. I don't know whether you get my point. So how does it affect the sensitivity to these organisms? Thank you.
There are guidelines in conducting antibiotic sensitivity testing using the Clinical Laboratory Science Institute procedure, and that was what we used. And we actually had selected antibiotics that were being listed out, and that was what we tested on. The antibiotics patterns that were listed out are the ones that we actually set out to test on. We followed the Clinical Laboratory Standard Institute to determine the sensitivity pattern. Well, the other thought is the issue of, maybe those that have used prior antibiotics, and maybe want to use further sensitive testing. Although in this study, about 20-25% had used prior antibiotics. And these are part of the limitations that was stated in this study. Use of molecular study, and that's why the recommendation for a further study is being propagated. So use of latex agglutination, use of polymerase chain reaction, which can even detect, even if they are dead organisms in the CSF. And that will further corroborate this study.
Sorry, what's your definition of a child in this study? You use 1 month to 14 years.
It's 1 month to 14 years.
So what informs you to choose that age range? Because you are defining a child. You are looking at ABM in children. Now, why 14? And then you said those that had contraindication to lumbar puncture, we excluded them. In a 1 month old child that's convulsing and having fever. So what were those things that you checked in the baby that you removed, you excluded them based on contraindication to lumbar puncture?
Standardly, there are absolute contraindications to performing a lumbar puncture in a child who presents with fever and convulsion. Signs of raised intracranial pressure is one key thing. Those that have bleeding disorders, those that have infections at the site of performing a lumbar puncture, those are absolute contraindications. However, in this study, we had only one patient who was contraindicated and was excluded from the study, just one. And so generally that was yes, the 14 years. Yes, because the pattern of seeing children, those less than 1 year, the pattern that you see in those less than 1 year and above 1 month and above 1 month is different. That's why 1 month old neonates were excluded. Now for the upper limit of 14, usually our center has we have a limit into those who we see in the pediatric department between the age of 1 and 14. And most studies actually use this age group as their cutoff for this study.
Age for definition for a child by WHO?
Yes, less than 18 is the general standard definition. Less than 18 is a child.
Yeah, my question is that what single contribution do you think this study has contributed to knowledge?
It has corroborated. It has brought out the fact that vaccination is key in preventing acute bacterial meningitis. And if you, but studies.
I think we know that before.
Yes.
That vaccination will prevent. That's no. I mean, something you think that is new that this study has contributed to knowledge.
Yes.
That vaccination will prevent meningitis is a known fact.
Yes, it currently gives the pattern, because what we knew before was that in Federal Medical Center in Bida environs, Neisseria meningitis was the commonest organism causing acute bacterial meningitis. And we should bear in fact that Bida is located in a meningitic belt. And so you expect that Neisseria meningitis should be the highest cause. But we've seen from a pattern that
meningitic belt, we're referring to Neisseria meningitis.
Yes.
So why is it going to streptococcus? Why?
Yes, that brings the fall of vaccination. Vaccination brings the fall.
Vaccination is not against streptococcus; it's against Neisseria meningitis.
No. We have vaccines against streptococcus, against Neisseria, and against Haemophilus influenza. And so we have vaccines and which are all deployed in that area against those 3 organisms. So now one of the recommendations here is to look at the serotypes of strep pneumo. Why is strep pneumo 4? It's because the vaccines that are being used currently is the pneumococcal vaccine, conjugate vaccine 10. It covers 10 serotypes. And there are many other serotypes of strep pneumo that could have been causing meningitis. So and that's why a further study needs to be done to look at which serotypes, the vaccines that are available against them, are they covering them? Are they the ones that are not covered? Maybe that's why we are having more of strep pneumo. Maybe the other serotypes, maybe those are the ones causing active bacterial meningitis. So if that study is further done, it will help to improve vaccines or bring vaccines that can cover those serotypes that are not currently available.
Thank you. I think there's a question from the audience. We'll just take that.
Yeah, thank you very much for the excellent work. I'm Dr. Alagbe, nephrologist. I'm just curious that out of about 100 children that had clinically suspected meningitis, only 7 ended up having meningitis. Is it that our clinical criteria for diagnosing or suspecting meningitis is faulty? What are the standard clinical criteria? And I'm just surprised that out of over 100, only 7. That means that clinically, without we must have to do lumbar puncture for all febrile convulsion to be able to pick up meningitis. Is that correct?
But in fact, one of the burdens or issues about meningitis and missing meningitis is that meningitis, the presentation can be non-specific in children. So a child can just come with fever and convulsion and he might be walking around and have meningitis. And that's why it is still being said that for you to, in fact, malaria can cause the features of meningitis. All right? Urinary tract infection can cause it also. So, and that's why you don't just assume that, fever and convulsion, most likely is malaria, MP is 1+, and no. So that's why these predictors came to 4. That if you see a child who is experienced less than 12 years, who has not been vaccinated, or who has any sign of meningeal irritation, think of meningitis, even if the child is looking like any other thing, and go on and perform a lumbar puncture. So the key thing here is non-specificity of the symptoms. Usually we talk about meningitis, you say meningeal irritation, you have neck stiffness, and co. You may not find it in a child who has meningitis. And that's why this is actually key here.
Standard care in BIDA is that every child walking into the EPU with fever and convulsion, age 0 to 14, you will lumbar puncture the child. That's what they're saying.
According to the American Academy of Pediatrics, the current standard of it, still, yes, is if a child comes in with fever and convulsion, especially if it's the first episode of his convulsion, he should have a lumbar puncture. And that goes around even worldwide. The American Academy of Pediatrics still validates that till now. Then there are some other sub-classifications. Child who is less than 18 years. By this study, it's saying less than 12 years. So that gives you a stronger suspicion. He should have a lumbar puncture if it's less than 12 years. Then from this study, if the child has not been vaccinated, he should have a lumbar puncture. Those are further strengthenings to that.
Okay, sir. Thank you.
Thank you, contestant number 6. Wonderful presentation. As we call on contestant number 7 to a round of applause for her, please. If the assessors are ready, we can have our dissertation. The time starts now.
Good afternoon, audience, panel of judges, my fellow contestants. I'm Dr. Ifunaya, and I'm presenting my research, cardiac troponin eye levels, and electrocardiographic findings in asphyxiated neonates in University of Uyo Teaching Hospital. Okay, so when a baby doesn't cry at birth, it's an emergency. Everybody is worried because birth asphyxia is one of the leading causes of death in the neonatal population, responsible for over 1 million deaths worldwide as reported by the WHO. The chronic hypoxia, that is lack of oxygen associated with birth asphyxia, affects all organ systems, and the heart and the kidney are the most important non-cerebral organs affected. It's been reported that up to 1/3 of asphyxiated neonates will have myocardial injury. And the problem is that the onset of this injury is occult. You may not know until you see signs of cardiovascular collapse, and at that point, your supportive measures may be late. Hence, the advocation of objective screening tools for diagnosing. Early detection of this myocardial injury will lead to early support and improved outcome, and that's the crux of this study. The aim of this study was to compare cardiac troponin I levels in associated neonates with that of non-associated neonates, and to determine the prognostic value of both in associated neonates in University of Uyo Teaching Hospital. The literature is suggestive that yes, the heart is affected in asphyxia, and cardiac troponin I levels may guide us into knowing which patient has been affected by this, as described by previous researchers. Also, J. et al., who pioneered a research on ECG findings in associated neonates, proposed a grading system which most other researchers have adopted, including me. This was a comparative cross-sectional study conducted in the newborn unit of University of Uyo Teaching Hospital. I obtained ethical clearance prior to commencement of the study, and from previous studies, a total sample size of 50 was calculated. 25 neonates who were aged 12 hours or less, who had moderate or severe beta asphyxia using a combined criteria of ABGA score of 6 or less in the 5th minute of life, and standard staging of 2 or 3, were recruited as the asphyxia group, while 25 age and sex match healthy neonates were recruited as a non-asphyxia group. Infants who had features of congenital anomalies, who were preterm or who were older than 12 hours of age, were excluded. After obtaining consent, relevant history and examination was documented. Then I assessed for cardiac troponin I level in the chemical pathology research lab of the institution using the mini-VIDAS machine by biomeru and enzyme-linked fluorescence assay principle, which is compact, fully automated, has room for single testing, and gave us results within 20 minutes. I also performed an ECG on all the patients, and the findings were graded 1 to 4 using Jedikin's criteria. The median cardiac troponin I level found in this study was 0.288 nanogram per ml. It was 13 times higher than that found in non-associated neonates, even as early as we took samples. And the higher values were found in those who did not survive, while all the non-associated neonates had values of less than 0.9, 0.1 nanogram per ml, considered to be normal. This is described in this graph here. We also saw that all the associated neonates had abnormal ECG findings, with grade 3 being the most common, while the non-associated neonates, only 3 had abnormal ECG findings. And this is described here. The blue is the non-associated neonates. Most of them had no abnormal changes. I also discovered that cardiac troponin I was a better predictor of mortality in associated neonates than abnormal ECG findings, with an odds of 35 for cardiac troponin I, while abnormal ECG findings had an odds of 5. These findings were similar to other studies, especially those who followed similar methodology, use of highly sensitive kits, and early assay. While abnormal ECG findings were in keeping with those by other researchers, and also abnormal ECG findings did not prognosticate death, like found in some researchers also. The uniqueness of this work is that cardiac troponin I levels were assayed as early as within 12 hours of age, which is an age where if you start your supportive measures, you will have a good result. Former studies focused on within the first 72 hours of life, because troponin I increases with age, and they wanted to do it when they're sure it to be elevated. But at that point, your resuscitative measures may be late. I also used a highly sensitive kit, which can detect as low as 0.01 nanogram per ml within 1 hour of injury. And my average age was at 6 hours. So at 6 hours, we knew the patients who had myocardial injury and the patients who did not have myocardial injury. And we could institute measures if needed. However, there's room for further research, as one will want to know longitudinal studies to monitor the recovery of these patients and how it correlated with abnormal ECG findings and the elevated cardiac troponin I seen. One could also decide to compare these markers of myocardial injury with markers of other organ injuries also seen in associated neonates to see which ones contributed more to mortality. And in my conclusion, cardiac troponin I levels in associated neonates was 0.288 nanogram per ml, 13 times higher than that observed in the non-associated neonates. Abnormal ECG patterns were also more in the associated neonates, and cardiac troponin I was a better predictor of mortality in infants with birth asphyxia than abnormal ECG changes. Recommendation: when a child doesn't cry at birth, while we focus on the brain, let's remember the heart. The heart is what's going to pump blood to the very valued brain. So, careful cardiovascular examination and screening is important.
Thank you, contestant 7. A round of applause for her, please. Questions?
Do we have any questions from the audience?
Yeah, good afternoon, everyone. Panel of judges and everyone here. Thank you very much for your presentation. ECG is a very important aspect in practice. I want to find out for your sampling method, you matched. You said you did a matching. So I want to find out whether you did a group matching or was it just an individualized matching that you did. Then for the ECG findings, what were the exact abnormality, that you found out? Because at the end of the day, you concluded that the troponin was more than 13 times or so more sensitive. So the ECG, in quotes, was not really necessary. So was it like an MI or something that you found out? So just let us know what exactly you find out. Thank you very much.
Thank you very much for the question. Unfortunately, the presentation is constrained because of time. However, I matched for age and sex. So if I have an asphyxiated neonate, male, 4 kilograms, I'll find a non-asphyxiated neonate, male, and 4 kilograms also, and sample for the patient too. Now, all the patients with breath asphyxia have abnormal ECG findings. So that is significant. We are not saying ECG is not necessary. What I'm saying is that for the issue of mortality, cardiac troponin I had a higher predictive value than the ECG. As in, it was better when we did logistic regression and predicted death better. The findings, the grading 1 to 4, according to JDAKIN, there's grade 1, which is abnormal T waves, and grade 2, abnormal T waves. Grade 3, which was the most common in our environment, is ST segment elevation or depression and abnormal QRS complexes, which was the most common thing we found in these associated neonates. So ECG is important. If that is what is within reach, then you start with that. But if you have services for doing cardiac troponin I, especially the highly sensitive kits, which can detect lower values, you can do that as early as possible and help the associated neonates survive better. That is the point of the study. Thank you.
Okay. How are you able to have these big neonates apply your leads and get ECGs and artifacts and all sorts of this thing? Because how did you do the ECG? And then if you want to intervene in an asphyxiated child with Apgar score of 6 or more, you don't wait for troponin I to go to chemical pathology. So why don't you use a point-of-care device for troponin I, which are available to people? Otherwise, the sensitivity could have been different. You send the sample to chemical pathology. You can't keep an asphyxiated child waiting for troponin I from the chemical pathology. Thank you.
Thank you very much, sir, for the question. It was actually a challenge to do ECG on the neonates, especially on the healthy neonates. However, because I did this ECG by myself and the instrument belonged to me, I was able to apply patience. For the asphyxiated neonates, once they have convulsions, they are usually given anticonvulsants, which are sedatives, which helps to reduce motion and reduce artifacts. For the non-asphyxiated neonates, we waited for when the parents had fed, when they were a bit calm. Our probes were not too harassing, and then we applied patience until we get a reading free of artifacts. Then we printed out the result.
Did you say probe?
No, sorry, the electrode.
Are you doing echo?
No, sir, the electrode, sir. Then for the point of care testing, unfortunately, the facility for that was not available, and it was out of my financial reach. However, we had results within 20 minutes. And unlike ELISA, which you have to do batch testing, our kit, you can do single testing, and I had access to the lab. So within 20 minutes of collecting samples, I was able to get the results and relay same to the management of the child. Thank you.
Thank you. way your methodology sounding like a case control study. Because you got cases, activated babies, looked for controls, non-activated, and then measured something in these two groups. So if you ask me, I would, adopt that method. It's actually a case control study, but I don't know what your supervisors thought. But I think that was the way to go. And then the sensitivity, I'm always interested in, if you're saying troponin A, is it a screening or a diagnostic marker? What would you call it?
Elevated cardiac troponin I is actually validated as a diagnostic marker for myocardial injury.
Okay. So it's not a screening. What's the difference?
A screening tool will let you know that there's a possibility that somebody has this condition, while a diagnostic tool diagnoses the condition in the person.
Okay, so in this, let me just, for the benefit of everyone, so the screening tool will pick more of the true positives, while the diagnostic would pick those who do not, the true negatives. Okay. So the diagnosis is more focused towards true negatives, and then sensitivity picks those who actually have the disease as diseased.
Thank you.
Okay.
Thank you, ma'am.
So thank you. So a diagnostic tool will have a higher specificity, while a screening tool would have a higher sensitivity.
Cardiac troponin I actually has a high specificity.
Okay,
it's
so
9%.
It's more of a diagnostic tool.
Yes,
okay,
ma'am.
Excellent. So thank you. Thank you. Okay, Prof.
I'm just wondering, what intervention really can you give in a patient, in those patients with high troponin, one level, high level? What intervention do you give?
Okay, thank you for that. For the patients with elevated cardiac troponin, one can give positive ionotropic agents. You can give fluid boluses. You know that when you are managing an asphyxiated neonate, there's usually this dilemma of fluid management because of the brain and the kidney. And also some people don't want to give these positive ionotropic agents because they are afraid of reducing blood flow to the kidney. But if you have the justification because of the elevated cardiac troponin, then you can intervene.
Which ionotrope are you having in mind?
Dopamine, dobutamine, sir.
So you give this?
Actually, we did in some of the patients, and we had a better outcome.
So how much
with
do you
them.
give a baby that is? How much of dopamine do you give them?
Okay, the 0.1 to 0.5 microgram per kg per minute. So you calculate it based on the weight of the child and put it in the IV fluid of the patient.
Sorry, I didn't hear how you calculated your sample size. What formula did you use?
I used the formula for the comparative cross-sectional study. That's the formula that I use. So I didn't include it in this slide. I'd included it in the further one.
25?
Yes, ma'am. I got 25. It was based on previous studies. Previous studies had similar sample sizes too.
Okay, so there's a limitation there.
Yes.
The sample size is small, so
Yes,
the
ma'am.
tendency for you to generalize your findings is limited.
Yes, that's also a room for further study for expanding the sample size.
Excellent. Thank you very much, contestant 6.
Thank you, contestant 6. 7, rather. Contestant 7. A round of applause as we welcome contestant 8. She takes her own dissertation. With the authority from the assessors, she can go ahead.
Good
Contestant 8.
afternoon, everyone. Staying on existing protocol. I am a dental doctor and oral physician, the only one in the house. So I worked on evaluation of selected biomarkers in temporomandibular disorders, short form TMDs. So TMDs are a broad group of clinical conditions affecting TMJ, that's temporomandibular joint, and muscles of mastication. And this TMD is a major cause of non-dental pain in the facial region, and also the second most common cause of musculoskeletal conditions following chronic back pain. This is the region. Okay, so far, diagnosis of this condition is based on history, physical examination, and imaging, and they have their own limitations. So there are recent advocacies for the exploration of inflammatory biomarkers in serum and saliva of these patients as a means of diagnosis and treatment monitoring. So a major objective of my study is to determine and compare the serum and saliva levels of these biomarkers, interleukin-1 beta and TNF alpha, in patients and the healthy control groups, and to compare these levels and the serum and saliva levels of these biomarkers in the patients. So for my methodology, my sample size was 50, 20 for the cases and 25 for the cases and 25 for the control. So for my methodology, following diagnosis of these patients in the oral medicine clinic, I'm an oral physician. These patients, their blood and saliva were collected, and after which they were placed on appropriate medication, and they were reviewed 2 weeks later. Upon their review, blood and saliva was also collected and sent to the laboratory for further for analysis. Following analysis, the result shows that all the patients with TMDs, they had high levels of these biomarkers in their saliva and their serum compared to the healthy controls. Also, within, that's interleukin-1 beta and TNF alpha. Also, within the cases, it's found that the salivary levels of these biomarkers were significantly elevated compared to their serum levels. And these levels were also reduced following treatment. Now, linear regression showed that age and gender had no effect on these serum and salivary levels. So what's the implication of my study actually? Now, number one, the data from this study has brought to fore the possibility of use of saliva as a diagnostic and prognostic tool in TMDs. Now, salivary diagnosis is an evolving area in dental medicine. And because saliva collection is easy, is non-invasive, and is cost-effective, as opposed to the use of blood. Also, this my study discovered that interleukin-1 beta, the saliva of these patients, was very, very elevated, so indicating that it could be a substantive biomarker for TMDs requiring further research. Now, if this biomarker can be substantiated, it will serve as a means of improving the treatment of these conditions. It will be a basis for development of targeted therapy against this biomarker, and this will help to stop the disease progression, as opposed to what we do regularly now is just treatment of symptoms. So if we have targeted therapy against this biomarker, it will stop the disease progression. So what's the major limitation of my study? Funding was a major limitation because it constrained the sample size and the duration of the study. So why is my study so unique? I can tell you my study is novel in our locality. To the best of my knowledge, no study has explored the serum and salivary levels of these biomarkers in these cases. And now my study has also brought, giving us a baseline data for these levels and giving room for further research. And also, it also enables everyone to know that the non-surgical management of these cases is within the domain of the oral physician. So in conclusion, I can tell you that now, based on my study, the serum and salivary levels of these biomarkers were higher in patients compared to the control group. And within the patients, the salivary levels were significantly higher than their serum levels. So what are my recommendations? For the researcher, an extended period of time is needed to really evaluate the impact of these therapies on the biomarkers. And we encourage the government to fund this kind of projects to enable us carry out this research on larger sample size, longer duration of time, so we can produce results that can be generalized to the populace. Thank you very much.
Thank you so much, contestant 8. Thank you. Questions?
Thank you very much. You are looking at interleukin-1 beta and TNF alpha.
Yes, sir.
Now, this was the cost of this test in your center. How do ESR and C-reactive protein fare in this population, which are very cheap? Because you are talking about targeted therapy in the future, because to get IL beta and IL-1 beta and TNF alpha, I know it's very expensive. I don't know what it is. Now you are going to test it again to drop after therapy. Now, have you looked at CRP and ESR in the population? Because TMJ disease is not a life-threatening condition like you are targeted therapy for malignancy. It's not
life-threatening, but it can disturb the quality of life.
So have you looked at CRP and ESR? You think you throw it and go to TNF alpha?
Okay. I didn't look at those ones because recent literature is advocating for exploration of interleukin-1 beta, TNF alpha, interleukin-6, and interleukin-8. So that was why I looked into these ones.
Okay, thank you. Do we have questions from the audience? Okay.
Thank you very much for the wonderful presentation. I'm Dr. Lawali. My question has to do with the specificity and the sensitivity of use of interleukins for TMDs, since there are other reasons why these things can be elevated. So what do you have to say about that?
Thank you very much. Yes, I saw that coming. As I said, this is the first of its kind, and going on, we're going to look into that. Because I know there are other conditions that these levels can be elevated. So that's also a kind of limitation, actually. But there are some things I did to eliminate some other things. Like these patients, no comorbid conditions. And most importantly, their oral hygiene must be optimal. I used an index anyway to assess the oral hygiene of this patient. So going forward, more research, we can consider knowing the sensitivity and specificity of these biomarkers in these cases. Thank you.
Thank you. Any more?
I was just wondering, would it not be better to be specific on the temporomandibular joint diseases that you're referring to?
I don't get so.
I mean, the TMD diseases,
okay.
disorders.
Yes, sir.
How many of them are they not different from each other? Why looking at all of them as a single unit?
Okay.
Don't they behave differently? The disorders are the
ones for the joints and the causes of mastication.
Yeah.
Yes. Well, they basically present pain, limitation in mouth opening and mastication. So the treatments are not so varied. Just that for those with masticatory problems, we add muscle relaxant. Otherwise, general NSAID does work for either kind of TMD.
Can you list all the TMJ disorders that you recruited?
Okay, the TMDs, and there are different criteria for them, but basically we have two broad groups. The arthrogenic, that's of the bone, and those of the causes of mastication. These are the two broad groups. Osteoarthritis will fall under the arthrogenic. The myofascial pain will fall under the muscular group.
Okay, thank you. One and only dentist. Thank you. Please let's appreciate her. Contestant 9. And thank you for keeping to time.
Dr. Ozegboya, I hope you know about Flodent.
Good afternoon, assessors, the audience, and my contestant. The title of my study is Randomized Control Study of 12 versus 24 hours Magnesium Sulfate Regimen for the Prevention of Postpartum Eclampsia in Pre-Eclamptic with Severe Features in the West of Ilorin Teaching Hospital. My name is Dr. Ogumi Oluwole, and this is my supervisor. Pre-eclampsia spectrum is one of the leading causes of maternal and perinatal morbidity and mortality worldwide. Magnesium sulfate has been proven to be the drug of choice and to be effective in its management. However, up to this moment, there is no consensus on the duration of postpartum maintenance dose of magnesium sulfate, and there are many protocols in use. And up to now, magnesium sulfate is usually administered for 24 hours postpartum or after the last convulsion in those that have eclampsia, even though there has not been any consensus on this. And there has been concern about magnesium sulfate stability, because magnesium sulfate used to be known as a drug with a very narrow therapeutic index, because the therapeutic range of 2 to 3.5 ml per liter is very close to the toxic plasma level of 4 ml per liter, and with increase in the plasma level, we have loss of deep tendon reflexes at 4 ml per liter, especially depression at 6 ml per liter, and cardiac arrest at 10 ml per liter. So studies have been done to actually find out if you can get effectiveness at shorter regimen. And many of these studies have been done, but they are not yet widely adopted because of insufficient data to have a change in treatment protocol. So why this study? I found out that if we have a shorter regimen that will give us the same result, that means risk of toxicity will be low. Also in my center, after delivery, many of these patients could not afford to continue with magnesium sulfate for 24 hours postpartum. And we realized that when they get it for a few hours, they do better. So that's why I put it to a statistical analysis to find out if it's actually working. Then also, those that have shorter regimen tend to ambulate early, then also make contact with their newborns, and also they have lower risk of developing deep venous thrombosis, which is also shared with morbidity and mortality. So the objective of my study was to determine the frequency of occurrence of eclampsia in the two groups, the 12 and 24 hours group, and also to determine the magnesium level in these two groups to actually find out if the shorter regimen will also increase magnesium level in the participant. And if eclampsia occurs, at what plasma level of magnesium does it occur? So my study was an equivalence randomized control trial, and pregnant women of at estimated gestational age of 28 weeks and higher, severe preeclampsias were recruited, and I calculated my sample size using sample size calculation for equivalence randomized control trial, and I had 84, 42 in each arm, and for which sampling method was used. So ethical approval was obtained at the institution Research Committee, and also I registered at Pan-African Clinical Trial Registry, and patient recruitment took place in emergency and labor ward, and my participants used a suspend regimen. Sample for magnesium sulfate, serum magnesium level was also assessed for, to know the baseline magnesium level, and these patients were randomized into 12 arms. So the outcome of my study was to find out if there will be occurrence of eclampsia in the two groups, and also to find out the maternal serum magnesium, time of ambulation, and clinical evidence of toxicity. So I collected the sample and I analyzed using IBM SPSS 26.0, and test of significance was done using chi-square, Fisher-Richardson, and tests of various types. Then the p-value was of less than 0.05 was said to be statistically significant. Okay. 98 were assessed for eligibility, and 39 were analyzed for the 12 hours group, while 35 for the 24 hours group. And this shows the demographic characteristics, and there's no statistically significant difference in the two groups, which shows that the randomization was properly done. Also, this table is showing the serum magnesium before administration of magnesium sulfate and 48 hours after, which shows that all of them had hypomagnesemia, which has been corrected at 48 hours postpartum. Then the result also shows that there was no occurrence of eclampsia in the two groups, and those in the 12 hours group ambulated earlier, and they breastfed earlier, and also expelled breast milk earlier, and compared to the 24 hours group. Then there was no case of toxicity in the two groups. Also, this shows that those that with severe preeclampsia were actually recruited and not with mild preeclampsia. Then with this, it's
You can use your mic now.
It has shown that hypomagnesemia is found in all the patients with preeclampsia with severe features, and which was corrected by the administration of magnesium sulfate. And also, the overall time of ambulation was shorter in the 12 hours group, and this has been found to be of good benefit to the women, because they're trying to have improving uterine involution, promote descent of lochia, encourage bowel bladder function, as well as prevent postpartum thrombosis. So in conclusion, the 12-hour regimen is as effective in management of preeclampsia with severe features, and it should be adopted as a treatment protocol in an environment, especially when there is a issue with cost. Then also, so I recommend that since a single center-based study, that this study should be replicated in other centers, so that we can have a protocol change in Nigeria, so that we can start adopting the 12-hour regimen, which will be helpful to our patient. And these are my references.
Excellent delivery on time.
So do we have questions? Thank you very much, sir. Do we have questions?
Questions from the...
One.
Thank you for the presentation. It was lovely. My main worry here is the regimen. You were using the Zupans regimen. So, is there any other studies that have looked at other regimens in terms of the Pritchard and then the Sokoto's regimen and all that? So, and in all those other studies, were there any improvement as to why you think we should follow the Zupans regimen in using the 24 hours or 12 hours postpartum magnesium. So I just want to know, are there other studies that looked at other regimens, and what was the outcome that prompted this? Thank you.
Thank you for the question. The reason why I chose Zuspan regimen is because that's the regimen we use in my center. So if I want to change the protocol, I should stick with the one that they are used to. Then also, in my literature search, I found out that different studies have also been done using preacher regimen, which also have similar findings of equal effectiveness as far as prevention of eclampsia is concerned. So I chose Zuspan because Zuspan is what we use in and preacher, because it is intramuscular injection, there is risk of injection abscess, then the pain at the site of injection. But with Zuspan, that is eliminated. Thank you.
So why do you think it's an equivalence randomizer, not non-inferiority? Why do you think it's equivalence randomizer? And then number two, how did you ethically, a woman coming, this has been the protocol, this is what science have determined, and you don't give her the choice to belong to whether 12 or 24 hours. How do you take care of the women agreeing to take the risk for going for 12 hours for something that 24 hours has been there?
Okay, sir. The reason why it is an equivalence trial is because I was trying to test whether they are of equal effectiveness, that one is not superior or inferior to the other. That was why I chose the equivalence randomized control trial. For how I was able to convince the patient, when they came to a counsel, I actually obtained an ethical permit from the ethical review committee. Then I explained to the women that even studies have been done that even tested a more shorter regimen. Some studies did just start dose. Some actually did 6 hours. And that those that did 12 hours, there has not been any risk associated with the findings. So it is safe. And if they are able to consent and we're able to get a valid result that can support our change of protocol, that they will be helping to contribute to protocol change and also help other women with the same disease. And they consented when they realized that there was no risk or a significant risk that will be involved.
Okay, thank you. So to the methodology, I'm wondering what are some of the potential sources of bias here?
Okay, thank you very much. The bias, the actual one that I was able to identify was that it was a single center-based study. So I could not say that if I have a finding at Ilorin that I will be able to generalize to people in Sokoto or Port Harcourt. But the other bias that could have been there were removed. Like in the case of, some studies actually recruited those with mild preeclampsia and together with the one with severe preeclampsia. So in my study, I made sure that those with mild preeclampsia were not recruited. And that was why even the blood pressure showed that the average blood pressure they had was 180 meters of mercury to 110. Many of them had proteinuria of 3 pluses. So they were actually patients with significant severe preeclampsia severe features that were recruited. And the bias was also that they were randomly assigned to the treatment group. And this was done by making sure that I generated a computer-generated random number from 1 to 84. So, and I ascribed A, B. A was 12 hours and B was 24 hours. So after assigning them, they were caught and they were put in an opaque envelope and numbered serially. If serial number 1 is picked, the number that is there, let's say it's 12A, that would be the person is assigned to 12 hours group. If it's 13B, the person is assigned to 24 hours group. So in that, I was able to remove any form of bias.
Okay. So where did the purposiveness come in? Because I saw, you said purposive sampling.
Yes, the purposiveness was for the fact that the patients used for the study were those who have preeclampsia with severe features and not the general population.
Because once you start introducing things like that, you're moving away from a randomized control trial and you're talking about a quasi-experiment, which is what I honestly think you did. Because even your explanation of the randomization, is because did you blind your participants at any point? Because the participants know that they were in study arm A for 12 hours or study arm B for 24 hours. Did the participants know?
No, ma. But they were counseled that at the point of recruitment that you have a serial number of envelope that the one you pick, if you pick a 12 hours group, pick B, you be in 24 hours group. And they agreed.
So the participants were aware.
They were aware that they could pick any of those or either of the two.
So where did you blind? Because in reading the final, did you blind at any point?
I did not blind at any point, ma. Because it might pose an ethical challenge if I blind. Because blinding will mean that those that ought to have stopped at 12 hours, I will need to give them something. And in patient with pregnant severe features, we have fluid restriction for them. So I could not put up a fluid for them so that they do not have fluid overload and cause pulmonary edema. So those that will stop at 12 hours, they stop at 12 hours. And then,
okay, you can actually blind at the end, where whoever is assessing A or B in terms of, some of the outcomes you said, should have been able to, without knowing which one is A or B. That will give you a more objective. But if you already know, this is A, this is B, and anybody would be biased. Will just go, A should have this, B should have, B is the control. Okay, so you must introduce some measures of reducing bias, especially when you're taking the final reading. That's why I asked you.
Okay. Thank you, ma'am.
What was the assessing? What was the outcome that you were assessing?
And the primary outcome was to assess occurrence of eclampsia in the two groups, whether they have convulsion or not. Then,
which anybody can assess, Abi?
Yes, sir. Okay. Then the other secondary outcome.
It's not that you measure the degree of convulsion or whatever. It's either convulsion
or no convulsion.
Yeah.
Then the other secondary outcome was serum magnesium level, the time of ambulation, the time, and then the toxicity. Magnesium toxicity, like loss of deep temporal reflex, especially depression and cardiac arrest.
So,
yes, we were doing deep temporal reflex hourly. Yes, sir.
So that's what we are talking about. So whoever would have done that should not have known who is in A or B, so that he doesn't bias his results and his objective. I don't know if you get what you are saying.
I understand, ma'am.
Okay.
And I guess you use multi-parameter monitor also for all of them.
Yes, sir.
We are doing respiratory depression. So for those, in your protocol before you enter this study, the maintenance dose is either 24 hours postpartum or 12 hours after the last convulsion.
No, sir.
That's what you presented.
No, the protocol in place now is either for pre-eclampsia or eclampsia. For those with pre-eclampsia, they will get the maintenance dose for 24 hours postpartum. For those that have convulsed, they will get the maintenance dose for 24 hours after the last convulsion.
So which we didn't.
Which we didn't, because I didn't recruit patients with eclampsia in my study.
So my suggestion is to take out that purposiveness. All women who met the eligibility criteria were selected. And then from there, you now do your sampling proper.
Yes,
okay?
Sir.
So
yes,
everybody who met your eligibility criteria were included into the study. Then you started the randomization proper. Not that you just, you have this, yes, you have an inclusion criteria, which is a case. What is your case definition? Okay, so the purposiveness didn't really. Okay, thank you.
Thank you, ma'am.
Did any of the patients with the shorter duration cross over to the longer duration of?
No, sir. What would have made, what I term as treatment failure, it was captured in the methodology that anyone that convulses after that 12 hours will transfer to the next group. In fact, will be taken out of the study. But none of the participants convulsed at any point during or after the treatment protocol. Whether the short or the 24 hours protocol. We don't have any case of eclampsia in the two groups.
Thank you, contestant 9.
Thank you.
Well
Thank you,
done.
contestant 9. As we welcome contestant number 10 to the podium. Are the assessors ready? Okay. Contestant 10, you can go. Your time starts now.
Good afternoon. Invited guests, panelists, for contestants, permit me to stand on existing protocol. I want to thank all the other presenters for laying a good foundation for cardiovascular disease importance. It's a cardiology day. I'm the only cardiologist here. So my research was on gender-related differences in clinical profile and outcomes of heart failure at Aminu Kano Teaching Hospital in Kano, Nigeria. I'll be presenting using this outline. So as an introduction, what is heart failure? It's a clinical syndrome. There are signs, symptoms due to structural functional abnormalities in the heart, and they're corroborated by elevated biomarkers called the natriuretic peptides, and evidence of congestion. It is the endpoint for all cardiovascular diseases. It is an epidemic. There's more than 60 million people affected globally. It has high morbidity, mortality, cost, poor quality of life, all of that, and accounts for up to 40% of medical admission. So it's a disease that we actually have in sub-Saharan Africa, and our mortality is much higher than the rest of the world, so unfortunately. Women are about half of heart failure patients, and they differ from men in terms of etiology, the treatments they receive, their outcomes and comorbidities. But unfortunately, we do not have a lot of sex and gender studies in Nigeria. In addition, a lot of our heart failure studies did not look at the biomarker. And generally, women are underrepresented in heart failure trials, including, despite the fact that the Lancet Commission on Cardiovascular Diseases in Women reports that cardiovascular diseases are the leading cause of death in women. So I aim to compare the clinical profile, specifically the demographic characteristics, clinical profile, and outcomes of interest, which were all-cause hospitalization, all-cause mortality, and left ventricular reverse remodeling, which is a marker of improvement. It was a prospective cohort study. 179 patients were recruited, so sort of one-to-one, who had symptomatic heart failure, and they were followed up for 6 months or until demise. They had extensive baseline evaluation, and at the end of the follow-up, those who were alive had echocardiograms and ECGs repeated to look at the recovery. We used this formula to calculate sample size and added 10% attrition. Because mortality was an outcome of interest, patients were excluded if they had other reasons that could cause early death, like cardiogenic shock, end-stage kidney disease, advanced malignancy. So I'll go through some of the results quickly, and I'll be discussing as I go. So if you look at the red box, the women, majority of them were in 20 to 29 years. That's very young. And a lot of the men were in their 60s. This brought the median age group. Age was skewed. This brought the median age group to 40 for women and 61 for men. So 2 decades difference. That's quite a lot. The women were unemployed. More of them were unemployed, and they had a lower income. The type of heart failure with reduced ejection fraction was the most common, as opposed to data from the West that shows that women tend to have like 50-50 preserved and reduced ejection fraction. What were the causes of heart failure? Peripartum cardiomyopathy was the most prevalent cause of heart failure. Just look at the gray bar. The second gray bar, that's peripartum cardiomyopathy, followed by hypertensive heart disease, while in men, hypertensive heart disease followed by ischemic heart disease. Rheumatic heart disease did occur, but it wasn't so common. And there were differences in terms of the treatments they received. Notably, the new drug, as sodium glucose co-transporter inhibitors that has been shown to improve survival, but is quite expensive, was given more to the men than the women. And the women received more of the older, less expensive digoxin that doesn't really improve survival. This might have been related to purchasing power. In addition, data from the US says that Black people don't have elevated biomarkers, but we see that our biomarkers were quite elevated, with a trend towards higher value in women, but the difference did not reach statistical significance. In addition, I was alarmed that these 20-year-olds were having dyslipidemia, abnormal cholesterol, as the same level as those old men, So the outcomes also didn't differ much. They died at almost the same rate. They were hospitalized at almost the same rate. This is a Kaplan-Meier survival curve. It appeared as if there was a trend towards better survival in females, but the p-value wasn't significant. The hazard ratio of 0.75 had a 95% confidence interval, which had crossed 1. So it wasn't really significant. So what makes this study unique? This is one of the few prospective heart failure studies in Nigeria that looked at the standard biomarker, which is the NT-proBNP. It is perhaps, to the best of our knowledge, the first prospective heart failure study that set out to specifically investigate gender or sex-based differences in outcomes in Nigeria. Cardiologists are obsessed with outcomes. Cardiovascular diseases causes death. And patients were so carefully followed up that the loss to follow-up was less than 3%. This is excellent in any type of study anywhere in the world. We had high rates of poverty and peripartum cardiomyopathy, and there were differences in prescription of the guideline-directed medical therapy. So I recommend a larger multi-center study, not because it's good nice to hear, but because there have been differences reported within the country, I recommend that we include cardiovascular disease care in maternal and child health programs, and we can cover heart failure in NHIS like we do for cancer. Thank you.
Thank you very much. Our last contestant. Do we have questions, comments, contributions? So 2 from the audience. Thank you.
Thank you very much for the beautiful work. Once again, my name is Dr. Alagbe. Good afternoon, assessors and everyone. So clearly, peripartal cardiomyopathy appears to be dominant in your population, and obviously that contributed to the difference in the genders. Now, if you remove that, because it's gender specific, men can have peripartal. If you remove that, is that gender difference, is it still there? And then I also wonder why, is there any reason why the women were not getting SGLT2 inhibitors?
Thank you. Thank you for the question. So yes, the younger age and a lot of the findings were driven by the large proportion of peripartum cardiomyopathy. If we look at the age, if you can put back the slides, please. If we look at the age in the women, it was skewed in both. It was skewed, but we have, apart from the prevalent 20 to 29-year-olds, we had, others like in their 40s and 50s. So these were more likely the hypertensive heart disease and all that. Because we wanted to look at the block difference between men and women, we did not exclude peripartum cardiomyopathy from the analysis to look at the other etiologies. But this may have influenced some of the other differences. 2 reasons why they may have received less sodium glucose co-transporter inhibitors. 1, the lower purchasing power. Majority of the women were earning less than 50,000 naira a month. So secondly, with peripartum cardiomyopathy, a number of them might have been breastfeeding, and SGLT2I safety in breastfeeding has not yet been established. There is data coming out to suggest it might be safe, but it's not yet recommended per se. So those 2 reasons, purchasing power and breastfeeding.
Most of the women that had heart failure, which class of the 3 heart failure do they belong to?
Reduced ejection fraction. Heart failure with reduced ejection fraction, and this was also probably driven by the PPCM, but also the hypertensive heart disease. Data from the West would suggest that heart failure or preserved and reduced ejection fraction have a 50-50 distribution, but repeatedly, data from sub-Saharan Africa, not just Nigeria, some of the large heart failure studies have shown that predominantly what we have is reduced ejection fraction.
I think it will be good to remove the distance and then look at it also in the larger final.
Okay.
Yeah. Thank you very much for the presentation, Dr. Ogide from LUT. I want to find out, is there a particular reason why the age is a bit skewed? That's one. Then also, just like a recommendation, if it's possible to probably reanalyze and extract data that you can, within the same age range. Because generally, study shows that in terms of heart failure, male and female difference is just about, I think, 50% on both sides. And like you said, most of these studies have not been done here. So if it's possible to really extract and compare within both, the same age group, maybe you can say maybe 40 to 60, and just analyze and let's see how it goes. It was a wonderful presentation. Thank you.
Thank you. I'll start with the second comment. So although we did not do age-based subgroup analysis, but to analyze survival, we did a Cox proportional hazards model to look at which factors determined mortality. And surprisingly, within the 2 sexes, so within females, age did not really contribute to mortality or survival. Same thing within males. But again, it's one way to look at age group based differences, if that would.
Thank you. So one of the major, for a cohort study, what was your main outcome?
The outcomes were rehospitalization or hospitalization, mortality, and then the left ventricular reverse remodeling, which is found out from comparing the baseline echo and the echo at the end of the 6 months. There are some measurements that are supposed to change in the positive direction.
Okay, did you find out was there any new outcome that you didn't already preempt?
So the outcomes were pre-specified. So these were the 3 outcomes that we were looking.
That's what I'm saying. Did you notice, because one of the advantages of a cohort study is that multiple outcomes. So you can go out to look for smoking leading to lung cancer, and you find other cancers.
Yeah.
So that's what I'm asking. Did you
So one
did
thing
anything spring up?
Yes. So one of the things that was evident from was the higher symptom burden in women, both at presentation but also at the end of follow-up. So even after they had recovered, more of them still had a higher symptom burden compared to the men.
Okay. So I'm thinking, like other people have suggested, if you take out something that looks like an effect modifier, that particular thing that they're mentioning, I've forgotten the name. If you take that thing out and do an peripartum and do another analysis, and we actually know, okay, this is for women, let us see if there's any difference. I think that would also improve the quality of the study. Right. Okay, thank you very much.
Thank you. Thank you very much. Thank you, dear assessors. At this junction, can I request the assessors, please just turn in your scoring sheets to my colleague. Just turn in it. Don't add anything. Don't subtract. No need to add. Prof, please release. Professor Samaila, please release. She will do the addition and what have you. Please. Thank you very much, dear finalists. Thank you for your efforts. I'm sure you all agree that we have taken something in from these beautiful and amazing fellows. I'm sure you agree. Please, a round of applause for the finalists again. Thank you all. Thank you very much. Thank you for your effort. It takes a lot to go into research and to comfort with what they are and to come stand before the audience to even talk to you on what they know. Right. So we appreciate you. Thank you very much, dear finalists. Thank you very much. So we'll just take a short break, recognize some dignitaries that just joined, some special guests, and at the end of the day, we'll go into this round 2. Round 2 for about 10-15 minutes for the rapid fire. Rapid fire where we want to see the fastest finger on basic medical questions. Those we projected, the fastest finger would rightly get the point. I already explained the rules. For rapid fire, right, images or questions will be projected on the screen. Each of our doctors, each of the finalists have a dedicated Samsung tablets. So they are all exposed to the same tablet. They are exposed to the same internet source. Unlike, was it last year, where someone used the iPhone and someone using Tono Survey, and at the end of the day, one was faster than the other. But this year, we have provided courtesy Shalina Healthcare. Please a round of applause for Shalina Healthcare. Thank you very much. These are technologies that we should appreciate. So everyone is exposed to the fairest of games, right? So there's the buzzer. Buzzer app has been imputed in each of the tablets. Our IT gurus will come around and show you how to go about that. Questions will be projected. The moment you know it, if you press the buzzer, right, you must answer within 5 seconds. If you answer correctly within 5 seconds, you get +2 marks. Right? If you answer within 5 seconds and you answer incorrectly, it is -1 mark. If you press the buzzer and you don't answer within 5 seconds, you lose -1 mark. The moment you see the question, you press the buzzer. Within 5 seconds, you must answer. If you answer correctly, +2 mark. If you answer incorrectly, -1 mark. If you press the buzzer and do not answer, -1 mark. I must also state that questions are not transferable. So the moment a question is addressed. That's the end of it. And that's why we must penalize for those that will press the buzzer and not answer. Because you might see some other finalists that might know the answer and you deny them the opportunity. So please ensure that you know the answer before you press. Then again, please, when you press the buzzer, it is at the behest of the panelists to call out your number, right, to tell you to go ahead. And the moment at the last word of the panelists, you have your 5 seconds counting. You must answer. So please, you have the prompting of the panelists before you would answer. Please. And everyone should be relaxed. You'll be on your seat. You don't need to stand up or anything, any movement. Be on your seat. The moment your number is called, you please answer. Right. So, Professor Samaila. If you are done, Prof, please turn it in. If you are done, please, don't need for your signature, sir. No need. Don't worry, don't sign. All right. So, again, I want to implore you, please, Shalina is yours. Please. Shalina is wholly 100% African. And that is what is the company that has come to stay. And that's why I told us earlier that the first world-class manufacturing plant in Africa is situated here in Nigeria, Lagos-Ibadan Expressway. Thank you very much, sir. And please, that is to tell you that it's a company that has come to stay. It's a well-run organization. It is not just also run. We have over 100 products across 13 therapies, and we keep looking, keep searching for more molecules on behalf of our people. So it's a wholly African company, started by an African Indian. African Indian because he was born and bred in DR Congo. And in the course of his life, he found the need to bring in essential products, took it upon himself, and went back to India, bought over one of the factories of Rambagzi. Today, over 100 products are coming from there. And today in Nigeria, we have over 100 products. Right. Our factory is also starting, and you can be sure that we'll be ready in a jiffy to also extend to the west coast of Africa to fill up. Right. At this junction, please let me, Dr. Onofeso, Esther, please, I want to request your beautiful pleasure to give our regards to Dr. Sixtus Ozumba. Dr. Sixtus Ozumba has always been, year in, year out, he has always been a family. He's always in the class, all rising star. Unfortunately, he sent his regrets that he couldn't be here today, and he told us rightly that Dr. Onofeso, Esther will represent her. So please, Dr. Onofeso, please give our regards back to Dr. Sisters. Then again, please, part of our team, right, Mr. Ilaji Musaya, the regional manager marketing, West Africa for consumer business, is also here with us. Where's? Right. All right. Then also Mr. Chaitanya Garikpitati, NSM Farmer Trade, is here with us. You're welcome, sir. Thank you for coming. He's just joined us in Nigeria as well. Then again, this session, this award ceremony was bettered. The idea conceived and nurtured by one of us. And I won't do good justice if I don't mention him and pay obeisance and recognition to him. Please join me as I call on one of us, our former manager, who actually championed and was the originator and of this program, both the Center for Pharmacy and the Rising Star for the resident doctors and young fellows. Please join me as we welcome pharmacist Folorunso Alaron. Thank you for coming. We appreciate you. Thank you. Then a lot also went into this organization. This session won't complete without recognizing some of my colleagues that have put in a lot, different committees to arrive at what we have today. Please, I want to recognize the marketing manager, Mr. Chuba. Thank you for coming, for your efforts. Mrs. Amina, our HR person. Thank you. The people's manager. Samuel, our brand manager. Thank you very much. Bolaji, IT. Thank you, Bolaji. Peter, our commercial excellence executive. Thank you, Peter. Thank you. Pelumi, our brand manager. Thank you. Chijioke, also of HR, Human Resources. Ngozi of Human Resources. Thank you. Zege. Zege is the one championing the food. Whatever you take in today, please all thanks to Zege. Thank you, ma. Sweet. Sweet is the one going around ensuring that everyone has a plate or two on their tables. She's also a brand manager. Right. Biodun, Fam Biodun is the one passing the microphone round. He's also a key account manager. Tolu is a CVD, cardiovascular team, regional manager for Lagos and West. Thank you, Tolu. Lolade, our Yabeji, she's the head of institution business. She's the regional manager for institution Lagos. Thank you to Lolade. Vivian, our delegate. Zainab, Deborah, Temilade, Jennifer, they are also our delegates, and we thank you for your effort. Uzuma is our zonal sales manager for Lagos and West. She's also here with us. Thank you. Thank you for everyone. Everyone has put in one or two efforts to make this day a reality. Thank you very much. I don't know. We are putting together the results before we go on to the second round. Right. So please, Bolaji, and Maxine. Sorry, I forgot Maxine. Maxine, thank you very much. The buzzer man. Maxine is the buzzer man. Thank you. So please, can we get them ready? Can we get the tablets ready, please? This is just about 15 minutes. And we would crave the indulgences of the audience. Please, we need absolute quiet. Because if you give absolute quiet, then we'll be able to get the questions right. We'll be able to know we'll be able to see clearly who has pressed the buzzer, who has been recognized, and the answers they will give. Please. All right. I want, please permit me to also, permit me to recognize the presence of Dr. Adeola Ajibare, the consultant cardiologist, LASUT Ikeja. Dr. Ajibare, you're welcome, sir. Just stepped out. Thank you. You're welcome, sir. So please, the IT gurus will go around and show you so that we get ready. While we are putting together these calls, Sorry, we are getting the tablets ready, please. While they also put together this course. Please, I'm sure you are. Please, Doc, take your Asu and Zobo. Please. Ladies and gentlemen, Dr. Afion, I understand there's no Asu in Calabar, and Dr. Afion has fallen in love with Asu. Please, Chijioke, can you assist me? Please, Dr. Afion, we need more Asu here. Dr. Afion has enjoyed it. Yes, sir.
You'll be recognizing people. While we are waiting for the tablets to be ready, let me specially recognize my classmate whom we went to the same medical school. We're in the same group. We graduated from medical school in 1993 together. I've not seen her again till today. Dr. Aramide.
Nice seeing you. Thank you for coming. Thank you.
She was a very vibrant member of the class. And you can see what Shalina Rising Stars can do. A classmate that I did 2 years ago. I'm here for the first time after we left medical school in this hall. Thank you, Aramide. We'll have a good picture and I'll send to the group.
Thank you very much, Dr. Aramide. Thank you for coming. Right. Thank you. That Rising Star is also about networking. Right. I'm sure even amongst the finalists, a bond is being formed today. You can interact with each other, get to know each other across the country. Incidentally, the finalists have come from different parts of the country, and friendship starts from there. There's a created WhatsApp group. The first edition, first season, the WhatsApp group is still existing. We've not locked it up, so they can still relate with each other based on specialties, based on whatever questions and queries. So that's the essence. It's the medical pharmacy are just a community, and you never can tell where each and everyone comes handy and important. Right. So thank you, Dr. Ramide. Professor Samuela, you want to confuse me. I went back there and they sent me back. Sorry, finalists. Please, dear finalists, I've been asked to still repeat the instructions for this round. Please. The moment the tabs are ready, the questions will pop up. Right. You have the buzzers within you. Right. Please, if you know the answer, you press the buzzer. So you press the buzzer. Right. Within 5 seconds, you must answer. If you press the buzzer, you don't answer within 5 seconds, you lose -1. If you press the buzzer, you answer within 5 seconds, you get lost correctly. You get +2. If you press the buzzer and you don't answer at all, you score -1. Right. So in case nobody presses the buzzer or nobody wants to attempt the question, then we'll skip that question. We'll move to question number 2 at the discretion of the panelists. Within 5 seconds, if nobody presses the buzzer, at the discretion of the panelists, we'll move to question number 2. I hope it's clear. Yes, please. No, the moment you press the buzzer, please, you have to wait for the prompting of the panelists to call out your number because it will display. We'll do a demo. We'll do a demo, right? And the moment you see those, if 4 people presses, the number topmost is the fastest. The number that is topmost is the fastest, and you have to wait for the prompting of the panelists. Call out that number before you answer within 5 seconds. Please, I hope it's clear now. Okay. Please, the room code is ready so they can log in. So please, for this thing you are using for username, please you are using your seat number, right? The room code, no, the room code will be displayed. There's it now. That's it. DUTJMA. DUTJMA. Why user number is your seat number, please. Don't use name, your seat number. Please. That's the room code. Capital DUTJMA. Please enter that for the room code. Your seat number is the user, please. That's where you choose the buzzer. The boss. That's where you press the boss. Right. please be aware, finalists, that it's cumulative. Whatever you scored during your presentation will be added to whatever you score here. Right. So it's cumulative. So if you're going to score -1, it will be deducted from your previous score. Please. So be sure, Dr. Uchena, be sure. Dr. Uchena is smiling. Please, we can do retrospective punishment. We can go and take from this, and if we can't get from your presentation, we'll go back to your zonal qualifier score. So again, please, the moment you press, you have 5 seconds to answer. Please. If you answer correctly, you get +2. If you answer incorrectly, -1. If you press and you don't answer at all within 5 seconds, it is -1. Please. So, yes. So there's a timer. He's using the timer.
There's a timer here.
He will prompt and tell you time up or this thing. So
once the time is extended,
yes,
I would let you know that it's time. Demo, please.
Demo, can you all test?
Say a question.
Sorry. We will start one after the other. Please reset. Number 1, please. Just test your buzzer. Let's see. Okay, reset. Number 2. Okay, reset. Number 3. Okay, number 4, reset. Okay, reset. Number 5. Okay, reset. Number 6. Okay, reset. Number 7. Okay, reset. Number 8. Reset. Number 9. Number 10. Okay, so all buzzers are working. Right. So we'll just do a demo. I'll throw 2 questions. So I think we are ready. I'll just give 2 general questions. And please, these are just general questions. Right. Okay, are we ready? What is the capital of Taraba State?
10.
Number 10.
Contestant 10, answer. Minus.
Abba, Doctor. Abba, Malama.
But we need a mic for the contestants. So I think yours can be here. Have to use your mic.
Where's that time?
Okay. So I think we have 3. We have 3 mics.
No. I think to be fair, so that we don't have lag in response, if the hall is quiet, just as we did last year, because once they press, the 5 seconds start from the system there, isn't it? Yeah. So once we say answer, so before you take mic, you may take 1 second. So I think they should answer the question, and we can hear them. Unless you want to be standing there with mic, after you give him mic, we time the 5 seconds.
Don't worry, we have our shout to lozenges, throat lozenges. If you shout and you inflame your throat, we have something for you, docs. Please, we have the shout to lozenges. Don't worry, we'll take care of you with that. So please, as the panelist just said, please speak out loud. Instead of me walking to you to give you the microphone or passing the microphone from one to the other, 2 seconds will have gone. And unfortunately, beyond this moment, I have no power to beg for anyone at this moment. I won't have any power to beg for anyone. Right, because
we also like the audience to cooperate with us.
Please.
So it has to be really quiet for us to.
Please.
So
Audience, right from the back. Please, absolute quiet, please. Absolute quiet, please. Right from the back, I beg you.
No whispering. No.
Please.
So please.
So question 10. Okay, let's do again. Capital of Uganda.
Contestant 2.
Kampala.
Correct. 2 points.
Yes, sir. Thank you. Dr. Abiye. Dr. Abiye, that is bedroom voice. Oh. All right. Everybody, bear me witness. I'm warning Dr. Abiye now. Bear me witness. So that's bedroom voice. So. All right.
Screen.
Yeah.
Media, full screen, please.
Sorry,
So, contestants, your focus should be on the slide with a white background. That's where the questions will come up. Questions will come up on the slides with a white background. Judges? Your reference will be on the buzzer. Good to pick. Contestants, slide with a white background. Questions will appear there. All the best.
All right. So whatever the score, please, the judges will call out the score so that it will be recorded. I play like joke.
One point for impartial. And also 1 point.
See, the panelists have been magnanimous and have asked me to convey to you, finalists, that if you give partial answer, even if it's not full, they'll give you +1. If you give partial answer, they'll give +1. Right. So that's also there. So are we ready, please? Panelists?
Yes.
Are we ready?
Yes, we are.
Alpha, Maxine, are you ready? Contestants, please, are you ready? Right. Let's go.
Contestant 1. Correct. 2 points.
Please clap briefly.
Contestant 10. Incorrect.
Time up.
-1. Sickle cell, actually. What is the diagnosis? They didn't say the cell. What is the diagnosis?
Judges, are you ready?
Yes.
Contestants, ready? Please do not buzz without seeing the question.
I think it's very important. This is circumstantial criteria. Because we never knew that someone would press ahead of even the projection. Honestly, it's a serious issue. Because we need to be very fair here. If you press without even seeing the question, what are you pressing for? There's no intention to cheat. So for this one, we did. But subsequently, anybody that presses without the image or the question being projected is -2, not even -1. Very important. Thank you very much.
Thank you, Prof.
Prof has brought the global standards in. Okay, contestants, please do not buzz without. Judges, are you ready? Contestants, ready?
5, contestant 5. Please speak up. So 1 point. Yellow fever and dengue fever. So 1 point.
Yes, again, before we continue, 1 point agreed. Yellow fever and dengue fever. Now, it appears here contestant was reading the question after pressing the buzz. So again, we need to be very, very careful because somebody is pressing just to get the 5 seconds to read the question within the 5 seconds, not deciding that he knows the answer. So that's very important. We penalize subsequently. Thank you.
Contestants, please speak up when you are called upon to answer the question.
Dr. Ifebude, please.
I need you to echo the answer. Do not read the question. Echo the answer once your number is called. Judges, are you ready? Contestants, ready.
5, contestant 5. Correct. 2 points. Please, let's clap for him.
Contestants, are you ready?
Contestant 6. Be specific, sir. Which one? Incorrect. Minus 1. That's marasmus.
Judges, are you ready?
Yes, sir.
Contestants, ready.
10. Correct. 2 points.
Please clap. Please clap. It's not easy. Baba Foley, clap. You don't know it.
Contestants, are you ready?
5, contestant 5.
Time up.
Time up. Minus 1. World AIDS Day.
Judges, are you ready?
Contestant 1. Median, correct. 2 points.
Contestants, are you ready? Judges, ready.
Contestant. Which? Correct. 2 points. We didn't have it.
Judges, ready. Contestants, ready.
2, contestant 2. Correct. 2 points.
Contestants, are you ready?
Three, contestant 3.
Time up.
Time up. Minus 1.
I think there are resident doctors here and there, so that sometimes we this is a monofilament for the assessment of peripheral neuropathy in diabetic patients. Monofilament. Thank you.
Judges, are you ready? Judges, what's the penalty? Okay. Reset. Contestants, ready.
Contestant 1. Correct. 2 points.
Contestants, are you ready?
Again, you cannot score 0 in GCS. The minimum you can get, even if you are dead, is 3.
Contestants, are you ready? Judges, ready.
Contestant 2. Correct. 2 points.
Okay, judges, kindly echo the answer because people are also listening online.
So that's the Terry John. 2 points.
Contestants, are you ready? Judges, ready.
Contestant 2. 4th of February. So World Cancer Day is celebrated annually on the 4th of February. Correct, 2 points.
Contestants, are you ready?
Contestant 5. Correct. So the answer is tension pneumothorax. 2 points.
How do you know it's tension pneumothorax on the X-ray? So pneumothorax, that's fine.
Technical team, can you please check on contestant 1? Please check on contestant 1. Okay. Reset. Judges, are you ready?
Yep.
Contestants, ready?
Contestant 7. Incorrect.
Incorrect. This is rhizosis sardonicus, or the devil's laugh. Tetanus, -1.
Contestants, are you ready?
Contestant 10. Correct. So elderly primary gravida above 35 years.
Judges, are you ready? Contestants, ready?
Contestant 1. Correct. Cleft lip is the answer. 2 points.
Technical team, please check on contestant 9. Also check on contestant 5. Please reset the buzzer. 9 balls. 9 balls. Reset the buzzer. 8.
See, please, the moment someone presses before they reset, no one can buzz anymore. So I'm sure that is what is happening. Until they reset, that's when you can buzz again. So if someone presses before you, right, it locks up in favor of that number. So they have to reset before you can buzz. So that's the issue. It's not as if there's...
So fastest finger gets buzzed. So the system automatically locks everybody out. 5, you want authentication, buzz to be sure you're okay. Buzz. Do it again. Reset. Reset. So we're fine.
You must press it from the center, please. Not at the edge, yes.
Contestants, are you ready? Judges?
Contestant 4. Correct.
Malaria, pattern malaria nephropathy.
Please, I will encourage our contestants to please speak louder. Please speak louder when answering.
So the species of Plasmodium associated with nephropathy, correct answer is Plasmodium malariae.
Judges, are you ready?
Contestant 5. Correct. So the diagnostic, which of the following is not considered diagnostic value for diabetes mellitus? Random blood glucose greater than 7 millimoles per liter.
Contestants, are you ready?
Contestant 3. Incorrect. So -1.
Epi or subdura?
It's actually subdural hematoma.
Yeah. So that's
Judges, how do you score?
So we've scored.
Okay.
So it's incorrect.
Contestants, are you ready? Judges?
We have to take that again, sorry.
Reset. Go. Go.
No, don't worry.
Oh, fastest finger.
Okay, this question has been overruled. Reset, please.
Contestant 10. Incorrect. Blount's disease is the correct answer. So -1. Right?
Contestants, are you ready?
Contestant 9. Yeah. What's the name of the chart? So you 1 point. Color blind. So it's used for color blindness, but what's the name of the chart?
-1 because it's Ishara's chart, isn't it?
So we'll score you 1 point for the color blindness, and the Ishara's chart is the correct answer.
Judges, are you ready?
So that's the final.
Okay, that's all. All right,
Thank you. Thank you very much. Please, a round of applause for our finalists. Thank you very much. I hope we also find this interesting. All right. So we'll be putting the questions and putting them together, and shortly we'll announce our top 3 winners. Right. You'll agree with me, it's been a day. Yes, please. It's been a day, and I'm convinced that 1 or 2 of us are taking some things back. At this junction, can I call on? All right. Let me also welcome Dr. Adedeji A.O., the head of family medicine, WAEC Medical Services. You're welcome, sir. Thank you for joining us. Thank you. Right. So at this junction, I want to call on 1 or 2 to come forward while we put the scoring together, to come forward and say 1 or 2 remarks. If you have any remarks, any feedback, would you request you at this junction to come forward and say and talk to us? Dr. Aramide. Thank you, ma'am. Please, a round of applause for her. Please. Thank you. So others, get ready. If you raise your hand quickly, I won't call. But the moment you don't raise your hand, I'll call names. Please, while she's talking, Professor Aimaku, getting ready.
Okay, remarks about everything, right? Yeah. So I sat down there, and I want to say thank you to Shalina Healthcare for this opportunity you've given to each and every one of us. It's my delight. I love medicine. And we sat down there and were saying, we love coming here. I had to call somebody when this was going on because of a lot we have learned, that we learn each time Shalina comes up, with this forum. We learned a lot. I know there was something when Professor, my friend, Samaila, when Professor Samaila said, when we looked at that picture of the patient with tetanus, I couldn't remember the name. So when the prof said, devil's laugh, I said, yes, I remember it ABU. That was a good one. So it reminds us of things we've forgotten. Another time I sat down there, I'm an endocrinologist, and then the Simmonson's Winston's, 10-gram monofilament. And I was watching, I said, man, there's no endocrinologist here. We should have gotten that. So it helps us to, it has helped us a lot to remind us of things even we've forgotten, So I want to thank Shalina Healthcare. I want to thank the panelists. That was a very good one. I really enjoyed. I sat down there and I enjoyed every bit of it. Shalina Healthcare, I want to say a big thank you. And we're going to encourage you more, even with your products. Those that come to me know that not only in the general hospitals, even in other private hospitals, your drugs are doing very, very well. And you're also doing well by giving back. You're giving back to us by having this forum. So I want to say thank you. And the panelists, a very lovely presentation, very lovely work. And I say all the best to you. Thank you very much.
Thank you, ma'am. Thank you. Professor Aimakun, please let's welcome Professor Chris Aimakun, one-time Sogon National Secretary, one-time Sogon National Vice President, all rolled in one. He's multidisciplinary. Thank you for coming.
I don't know where to start, but thank you to my friend Ayo, who I met accidentally. And he led me to Shalina. And since then, it has been no go for me. It has been always there. I've been to their factory. I follow them wherever they go. This is the 4th Rising Star. I missed the 3rd one because I wasn't in the country, and I was ashamed each time I see him that I couldn't be there. But there's something about the giving back. Not many drug companies give back. We don't know how they are progressing. I was surprised to see the area of products that they have and how well they are doing and how they are trying to improve the markets. But more importantly is how we learn. I sat down there with my friend. I was trying to remember some of these pictures. I'm a gynecologist and I don't do much of general practice. But when you see come to this kind of forum, it makes you remember a lot of things. So I'll ask the management to keep on doing what you're doing. It improves every year. I mean, you go from one, I think the last time was at in Radisson Blue. It's improving all the time. I'm looking at my time. I have to get back to Ibadan now, and I'm thinking, no, I can't. I must wait till the end. So just keep on doing what you're doing, and Rising Star, the limit is above the Rising Star. Thank you.
Dr. Kiran, did you hear that? Can you quote him, please? Dr. Kiran, I want you to say what he just said. Rising above the stars. Thank you, Doctor. I don't know. Okay, then. Dr. Olowo Jebutu, representing the NMH president, national president. Thank you, sir. Thank you.
Okay, so good afternoon, ladies and gentlemen. Can you hear me put your hands together for these amazing people on this table? You guys have shown a lot of capacity today. I celebrate all of you. It was a very powerful presentation. Everything was on point. Thank you to the panelists too for what you've done. I bring greetings from the president of NMA, Professor Bala M. Audu, to say thank you for what Shalina is doing to Nigerian medical doctors. I think it is worth celebrating. You've done a lot of work and you're impacting the community. This is what we call investment in the future. So let's keep doing what we are doing, improving healthcare practice in Nigeria. And I know Shalina is part of the progress. Doctors, young fellows, you've done well for us today. NMA celebrates you, and we appreciate what you're doing. God bless you. Thank you.
Thank you. Thank you very much. Thank you, sir. Regards to the national president, too. All right. I don't know any other person that wants to. Thank you very much. Come forward, ma. Yes.
Good afternoon, everyone. I must say I appreciate Shalina. This is the 4th season, and I've never missed any season. This is the 4th one I've come, and I've been coming since they've been organizing it. And I must say that they are improving from time to time and from year to year. I must say Shalina is doing a good job impacting knowledge, promoting knowledge, and encouraging young doctors to come up with good researches. I congratulate you and encourage you to continue the good work. I also want to say thank you to the panelists because it's not an easy job. You have presentations and cases and researches from all over Nigeria to be able to come down with the best 10. And I must say, these are actually the best 10 because the researches are to point. Lovely. Well done, well researched, good topics. Let's give them a round of applause. For my own contribution, please, Shalina, where in a society like this, where people are promoting nudity, look at Big Brother Africa. This is a laudable presentation, a laudable program. This is the 4th season for crying out loud, but we are not broadcasting it. It's not in the news, it's not on the media. Nobody knows about it. So please, when you're doing next year's own, please look for sponsors and broadcast it. Let people know and encourage let us encourage people to promote knowledge and learning and academic pursuits. Please, this is very, very good. Thank you very much.
Thank you very much, ma. And your feedback is noted. Thank God our agents are all here, and we'll take it from here. Dr. Kiran, please note that down. Thank you. Please, who else? I don't want to call. I want volunteers. Yes.
Well, let me also comment. I think this season's is particularly very interesting. Number one, all these contestants, they are winners. It doesn't matter who eventually wins today. But because this year's dissertations were excellent. Fantastic work, okay? And it was quite difficult to even choose 10 among the ones sent to us. But these are really very great works. And they've spent so much time, energy, and resources, people analyzing and all kind of markers and all that. And if you look at it, 3 of us scored, okay? And we didn't know anybody. And people are from all over the country. And that means you have the best from anywhere you go in Nigeria. Go to the north, go to the east, go to the south. There are great people everywhere. And Shalina, thank you for bringing all this greatness out of Nigeria. God bless.
Thank you, sir. We appreciate it. Thank you. Anyone else? Okay, I understand the scores have been verified by the panelists and also screened by what's that our Sanjay by Enza Young. I mean, what's that our Sanjay? That's your scope now. Sorry. Okay, so we have the 3 toppers, but we only announce after taking lunch. I think we are taking lunch. Who wants to take lunch? Who wants us to announce now? Are we announcing now? Because we still have lunch. We have to feed you. Right. Dr. Adede, he said we should eat first. That is feeling fatigued. Dr. Adede, he said we should eat too. Right. Tolu? Please, can you get Tolu from Vivian? Please, help me get Tolu. Please, quickly. Tolu Ruth. Peter. Yeah. Flags. Tolu? Come on, take this. Come on, take this. interlude. I don't know if there are people that still want to talk. The floor is open. All right, at this junction, can I call on our head of Farmer Business West Africa to say one or two things to the audience? Some remarks from our head of business Farmer West Africa. Thank you.
Good afternoon, everyone. It was a wonderful day. It was a wonderful day so far. While I keenly look forward to the results, I've made some points out here which I wanted to share. First thing is that I feel every contestant, and this has already been said, is going to be a winner, without a doubt. Every presentation, every dissertation was interesting. It was so good to see all the local issues which were highlighted in this forum. It's wonderful. And I'm so happy to see that Shalina is able to help showcase that the medical talent which is there in Nigeria. This is one of the forums where we are able to showcase it, and I think this is a forum where we can show that the medical fraternity, how advanced the thinking is, how advanced the research which is being done is, and what is the talent which is hidden in Nigeria. And Ma, what you said that what can we do to propagate this program more, advertise about this program more, show it to as many doctors as possible. We'll be doing our best in the next season. We are continuously improving. We are still young. This is the fourth time that we are doing it, and we hope with your help and your support, we'll have many, many more seasons to come, and we'll see many, many more rising stars. Last of all, I would like to just say that we are here with your support. We are here in Africa to grow. We are here to give back. And from that context, we have our factory here. I'm very happy to say that thanks to all the support from the medical fraternity, that we are planning to expand the factory and in fact see how we can export from Nigeria, make in Nigeria and export to the rest of Africa by expanding the lines that are there in the factory. Some of you may have visited. I'll try and see how we can organize more and more visits for the medical fraternity to our plant to see our capability, and we'll seek your advice. Humbly, we'll seek your advice and opinion on what we can do to improve our plant further and see what are the opportunities to bring medicines and cutting-edge solutions for the medical issues which are plaguing sub-Saharan Africa. There is another software, I don't know if most of you may be aware or may have heard our medical delegates come and talk to you. It's called MedSpace. It's basically a platform where you're getting a lot of research, a lot of articles which are posted. Some of it, if you actually go in the net and try to hunt it out, you would have to pay for it, but it's all available. And it's just a matter of registering yourself and being on that platform, being able to network with all the doctors, not just across Nigeria, but across many more countries, and seek and interact with each other to help improve the health of the patient and be a better health care provider. So these are my thoughts for today, and I think, while we look forward to the winners, I wish all the best to all the 10 contestants and the many more contestants who participated as you step into becoming a healthcare professional and doing your best for your patient. Thank you very much.
While we are waiting for the result, let me call on the head of demand generation for institution business, Dr. Kiran Prakash, to please add some of his thoughts.
Wow. So I want to thank all your doctors for coming. First of all, a lot of people thank the contestants and the panelists. I also want to talk and thank very profusely our esteemed doctors who left a busy practice to come and be with us. Please, can we clap for them? Yeah. And whatever has been said has been said. I think it is very surprising and to see how amazing and what kind of talent we have in Nigeria. And also the depth of research. For somebody who's coming from India, it is very, we always assume that most of the research is done outside Africa. But then when you see these presentations and dissertations, you see the kind of depth and the quality of work is actually coming from Nigeria. So I am somebody whose motherland is India and my motherland also is Nigeria. I'm proudly Nigerian myself. So she has a name for me, and it's Baba Tunde. So we really want to take your support to actually continue the kind of medical programs that we do for all the doctors. We are currently getting very deeply into the cardiovascular space. We have an ongoing antibiotic stewardship program where we have covered almost 70 hospitals. And at the same time, while we do all these things, we keep a patient-centric approach. Okay, so we do a lot of market clinics. We also want to solicit your partnership to partner with us and to let us know how we can come in to actually do a lot of screening programs. So once again, I want to thank everybody and wish all the 10 contestants all the best. Thank you.
Shalina Healthcare presents Rising Stars Season 4 Grand Finale, a unique platform for medical professionals to showcase their clinical talents. Who will be the next winner? Over 786 doctors across the country participated in the qualifiers. The top 10 finalists from 17 hospitals will compete at the grand finale. Who will walk away with a 1.2 million naira grand prize? Join the Shalina family in our quest to find out our next stars. Prizes: first prize 1.2 million naira, second prize 700,000 naira, third prize 400,000 naira, and there'll be consolation prizes. This year's Rising Stars will be held physically on February 11, 2025 at NECA House, Alausa, Ikeja, Lagos. Virtual participants can watch live on PharmaStream TV's YouTube and Facebook channels. Subscribe, like, and click the notification bell for instant updates. At Shalina Healthcare, we partner with medical professionals to deliver quality care for all. Shalina Healthcare, celebrating 40 years of trust.
You should be the next singing superstar.
Has dull and uneven skin tone taken away your confidence? Presenting Shalina Healthcare's new Epiglow. With power of triple radiance complex, an innovative technology that gives you glowing skin by reducing dark spots in 28 days. Skin science for a perfect glow. New Epiglow. Skin science for a perfect glow. New Epiglow.
As a mother, I'm always ready to keep my family safe and healthy.
Wow, we won the match!
I'm proud of you, son. Well done.
Thank you, Mom.
It's time to fight the germs.
Jamo soap?
Hey there, little hero.
Miss Jamo?
Want a football match?
Yes.
Now it's time to win against germs with Jamo Shower.
Jamo, it's all in one. Care and protection till the job is done. Jamo.
You are a woman of mystery, brushed with beauty. You are a woman of enigma, layered with personality. You are a woman of elegance, painted with desire. Presenting Mona Lisa, a new range of moisturizing lotions and creams enriched with the finest ingredients for 48-hour moisturization. For women who are art, for women who are beauty. New Mona Lisa. Come discover the art of beauty.
The world of boxing is in shock. The highly acclaimed champion, Mr. Three Blows, has fallen ill. Mr. Three Blows experienced malaria symptoms. Will he be able to deliver the knockout performance we've come to expect? Will he be forced to withdraw?
Mr. Three Blows, you know how much I don't bet for it? I got stand up with you. Oh yeah, cake. Make use and sharp. Shall I tell you too sure?
Mr. Three
Mr. Three Blows and his fans celebrate victory thanks to Charlatan anti-malarial drug.
Charlatan, which contains artemether and lumefantrine, knocks out malaria in 3 days. If symptoms persist, consult your doctor.
It's another day to get out there. Head out for sustenance. Work for the future. Life can be good or painful. For those painful periods, you always have a partner to count on. Ibucap is always with you, giving you the desired relief from pain. Ibucap capsule, always with you to beat pain. Marketed by Shalina Healthcare Limited.
The world of boxing is in shock. The highly acclaimed champion, Mr. Three Blows, has fallen ill.
You know how much I don't bet for it? I got stand up with you. Oh yeah, cake. Shall I tell you too sure?
Three Blows and his fans celebrate victory thanks to Charlatan anti-malarial drug.
Charlatan knocks out malaria in 3 days.
Is there anything you want to say to me?
So, take Shalto.
It has the power of 5 natural active ingredients that clears your throat when you need it the most. Shalto, get your voice back.
My tutu. I don't want to live without you, tutu. Will you marry me?
Think natural. Think Shalto.
Just for you. I ate so much fried and spicy food at the lunch today. Right now, I'm having heartburn and indigestion.
Say yes to Polygel Dual and no to heartburn and indigestion. Polygel Dual provides double action and rapid relief. It neutralizes excess stomach acid, stops acid rise by forming a protective layer, starts working in 25 seconds, and the effect lasts for more than 3.5 hours. Polygel Dual help you maximize every moment.
Your Honor, my client is not guilty.
Then let him say that he is not guilty.
Sir, I'm guilty. Section 2.
It has the power of 5 natural active ingredients that clears your throat when you need it the most. Shalto, get your voice back.
No, Your Honor, I am not guilty.
Then you are free to go.
Think natural. Think Shalto.
Don't worry, sir. It's a simple procedure, okay? Give me this cup. No. Give me this cup.
Okay, take shout to me.
It has the power of 5 natural active ingredients that clears your throat when you need it the most. Shalto, get your voice back.
Procedure successful.
Think natural. Think Shalto.
Is there anything you want to say to me?
So, take Shalto.
It has the power of 5 natural active ingredients that clears your throat when you need it the most. Shalto, get your voice back.
My tutu. I don't want to live without you, tutu. Will you marry me?
Think natural. Think Shalto.
Your Honor, my client is not guilty.
Then let him say that he is not guilty.
Sir, I'm guilty. Section 2.
It has the power of 5 natural active ingredients that clears your throat when you need it the most. Shalto, get your voice back.
No,
Your Honor, I am not guilty. Then you are free to go.
Think natural. Think Shalto.
Mom, Dad, it's time to get up and brush your teeth.
Oh, I don't want to brush my teeth.
But it's not just any toothpaste, it's Flowdent.
Oh, the one with the ingredients that give strong white teeth?
Uh-huh.
The one with mint for all-day freshness?
Uh-huh.
Well, in that case, we will happily brush our teeth.
Packed with the long-lasting freshness of mint. For fresh breath every day, Flowdent toothpaste. Your kids will love it, and you will too. Flowdent. Grab life, grab the freshness.
You should be the next singing superstar.
Has dull and uneven skin tone taken away your confidence? Presenting Shalina Healthcare's new Epiglow. With power of triple radiance complex and innovative technology that gives you glowing.
At Shalina Healthcare, we started nearly 40 years ago, and it was based on an understanding that Africa needed quality medicines at an affordable price and that were available there on the ground.
We see ourselves as part of our vision to be Africa's health champion.
We are focused on Africa, and we serve a whole host of countries across sub-Saharan Africa. So we started in DRC. From there, we went to Angola, then to Nigeria, Ghana, and French West Africa. Then on the east side of Africa, we're in Kenya and Zambia. And we're expanding every day.
One thing that I believe differentiates Shalina Healthcare from other pharmaceutical businesses on the continent is that our approach to each market is almost unique.
And so that means that we really understand the markets that we're in and how exactly to do business. We are a healthcare company focused on pharmaceuticals, consumer health, and diagnostics. As part of our growth ambition, we're entering into new therapy areas and new businesses. We believe in local manufacturing in Africa because it is important that the countries we serve become self-sufficient for their medicines.
Shalina Healthcare has historically always sourced its pharmaceuticals from either India and China. And in the last 5 years, we've strategically decided to expand our manufacturing capabilities onto the continent, made in Africa for Africans.
All of the plants that we manufacture in, be it our own plants or third parties that we partner with, all meet WHO GMP standards as well as the local regulatory requirement of every single country that we're in.
Good manufacturing practice, along with the quality controls, give us what we call quality assurance.
We'll also be entering into new countries in North Africa as well as South Africa. And we're going to do that by really building on the strengths that we have, where we really understand Africa and what its needs are.
This profound understanding has ignited and fueled our growth in consumer product range, expanding our current portfolio and crafting a robust go-to-market strategy across Africa and Middle East.
If you travel to any part of Africa, people recognize this company. So our products are very popular across the continent. And if you see the customers who come to our shops, for them, we are the first choice.
We are really committed to community outreach. We bring doctors, we bring nurses, we bring testing capabilities, giving them free medical attention and giving them free medicines.
In Shalina, most important are our people. We take care of our employees. We help them to develop themselves.
We don't struggle to be creative. We don't struggle to innovate.
The pursuit of our excellence not just stop at employees, it's also at the level of customers. Like the Shalina Young Talent Award for identifying the best talents in the pharmacy, or with a program called Rising Stars for the doctors when they are doing their internship.
I feel proud. I'm in the company 22 years. Healthcare has improved a lot.
We're committed to being in Africa. We've been there 40 years. We will certainly be there 40 years from now.
We want to have a lasting legacy where people can see the impact that we are making on the lives of millions in Africa.
At Shalina Healthcare, we started nearly 40 years ago, and it was based on an understanding that Africa needed quality medicines at an affordable price and that were available there on the ground.
We see ourselves as part of our vision to be Africa's health champion.
We are focused on Africa and we serve a whole host of countries across sub-Saharan Africa. So we started in DRC. From there, we went to Angola, then to Nigeria, Ghana, and French West Africa. Then on the east side of Africa, we're in Kenya and Zambia. And we're expanding every day.
One thing that I believe differentiates Shalina Healthcare from other pharmaceutical businesses on the continent is that our approach to each market is almost unique.
And so that means that we really understand the markets that we're in and how exactly to do business. We are a healthcare company focused on pharmaceuticals, consumer health, and diagnostics. As part of our growth ambition, we're entering into new therapy areas and new businesses. We believe in local manufacturing in Africa because it is important that the countries we serve become self-sufficient for their medicines.
Shalina Healthcare has historically always sourced its pharmaceuticals from either India and China. And in the last 5 years, we've strategically decided to expand our manufacturing capabilities onto the continent, made in Africa for Africans.
All of the plants that we manufacture in, be it our own plants or third parties that we partner with, all meet WHO GMP standards as well as the local regulatory requirement of every single country that we're in.
Good manufacturing practice, along with the quality controls, give us what we call quality assurance.
We'll also be entering into new countries in North Africa as well as South Africa. And we're going to do that by really building on the strengths that we have, where we really understand Africa and what its needs are.
This profound understanding has ignited and fueled our growth in consumer product range, expanding our current portfolio and crafting a robust go-to-market strategy across Africa and Middle East.
If you travel to any part of Africa, people recognize this company. So our products are very popular across the continent. And if you see the customers who come to our shops, for them, we are the first choice.
We are really committed to community outreach. We bring doctors, we bring nurses, we bring testing capabilities, giving them free medical attention and giving them free medicines.
In Shalina, most important are our people. We take care of our employees. We help them to develop themselves.
We don't struggle to
Axel, TGOK, please come and take position.
All right, so we'll be making the announcements now for the third place position. Third place position, let me call on Dr. Ogide, please come out, please. Dr. Onofeso, Dr. Oshinowo, and our MD. Please, can we have you on stage, please, to help make presentation to the third place winner. Dr. Ogide, Dr. Onofeso, Dr. Oshinowo, along with our MD. Please come up stage, please. Please clap for the presenter. Each of them, Dr. Oshinowo will also present to us 5 minutes. Give us a 5 minutes presentation. Dr. Oshinowo, 5 minutes presentation, followed by Dr. Ogide as well. It's not easy what the finalists have done. I'm sure you will agree that they've done well. Right. So please, let me call on the third place winner today. Please jam your hands as we call on the third place winner today. Everyone is a winner, and everyone is going home with a gift. There's a prize for everyone, that I can assure you. All right. Please, third place winner. Third place winner. Please jam your hands. Please, as you jam your hands, to be led by Dr. Afyong. Please jam your hands as I call on Dr. Ifunaya Ularima Ebiepe. Dr. Ifunaya is from the University of Uyo Teaching Hospital. Prof said I should have crammed the 10 dissertations. Can you imagine? Please, a round of applause. She has done well. Everyone has done well. But of course, we must choose our top 3. She's going on with a cash prize of 400,000. 400,000 for the third place winner. Dr. Ularima Ifunaya Ebiekwe from UUTH.
Yeah.
Thank you very much. All right. While our MD remains, I will claim, I thank you, Dr. Ogide, Dr. Oshinowo.
The topic, I think she was the one that worked on cardiac troponin. Associated babies.
Okay.
Thank you.
Doc, please, are you
Okay, my topic was cardiac troponin high levels and electrocardiographic findings in associated babies in University of Uyo Teaching Hospital, comparative study.
Congratulations. Thank you very much. Thank you. Now, for the second place prize. Okay. Second place to assist us to make presentation, Professor Aimaku, Dr. Mifta, Dr. Shotubo, along with our MD. Professor Aimaku, Dr. Mifta, Dr. Shotubo, along with our MD, will help present second place. And the winner, second place winner. Second place winner, ladies and gentlemen, Dr. Rukaya Nasir Sonny from AKTH Kano. Peter. Media, please let me announce before you display. Kabiru, Rice, Z. Please clap once more. Dr. Rukaya Nasir Soni from AKTH Kano. Dr. Rukaya. Dr. Rukaya, please, can you tell us the topic of your...
My topic was gender-related differences in clinical profile and outcomes of heart failure at Aminu Kano Teaching Hospital.
Very much. Thank you. Now to help present the first place, the best brain currently in the country. Either you like it or yes, the best brain in the country, a young fellow, resident in Nigeria today. And I can assure you, this fellow will not jackpot. He or she is staying back to help listener. I know, because until he exhausts our Shalina product, he's not jackpotting anywhere. So please let me call on our head of pharma business, Mr. Amitav Basag. Our MD is already on stage, and the representative of the NMA president, the first vice president, please join us to make the presentation to our first place winner. Please take position, please. Maxine, take position. Where's Chijioke? Take position. Yeah, Samuel, decide. Samuel. Okay? It's been a long journey. This journey actually started in October last year when we started going around each of the institutions to do the Day of the Rising Star. And as I said, we got cooperation from many of the institutions, and we were exposed to over 756 doctors, residents, and young fellows. Today, we are here with the top 10 finalists, top 10 dissertations, and just like the panelists said, that they went through, it was Herculean, dissecting those dissertations before arriving at their scores. So that is to tell you that everyone here is a winner. We are proud of you. And please, we expect that from here you are only rising higher. Please, you have to live by the name of this competition, Rising Star. You can only rise higher. You are not permitted to go low from here today. That I want to assure you. And please also remember that we are partners in progress. Shalina and the station resident doctors, young fellows, and the medical fraternity in Nigeria, Shalina is ever with you. Right, the NMA. Thank you, sir. NMA, the SOFPON, the SOGON, what have you? Professor Emaku, every medical association, Shalina is with you. We're ever with you. And I want to call on the winner. CITA season 4. CITA season 4. Rising Stars season 4. Please don't blame me. We were here last week shouting CITA. Rising Stars season 4. Please join me as a welcome and celebrate the winner. The best young clinical talent in the Nigeria hospital industry today. Please join me as I call on Doctor. He's a doctor. The winner is a doctor. I think I've given you enough. The winner is a doctor. Doctor. He said he's a farmer as well. So, doctor. Where's the name? Doctor. He's a doctor. She's a she. He is she. She is he. He is she. Please join me as we call on the best brain today, Dr. Odedeyi Akinola Yodeji from Obafemi Awolowo University Teaching Hospital. Please clap.
Number one and nothing
is the recipient, the winner, 1.2 million. Going up with 1.2 million.
Waited patiently. I have vision, though I believe. I know I can count. Stand up for the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions. Stand up for the champions, for the champions. Stand up.
All right, the other winner, second and place. Please come forward.
Here we go, it's getting close. Now it's just who wants it most. It's just life, that's how it is. 'Cause we have our strengths and weaknesses. Oh, I have vision, look, can't you see? I'm on the move, make way for me. Stand up for the champions, for the champions. Stand up, stand up, stand up for the champions.
Dr. Dede, you need security.
Stand up.
You need security. Carry his cash.
Stand up, stand up, stand up for the champions, for the champions. Stand up.
Please, panelists, please.
And when I fall
Panelists,
down,
you also take pictures with them.
I have
Finalists.
to pick myself back up. And when I fall down, I have to pick myself back up. And when I fall down, I have to pick myself back up. And when I fall down, I have to pick myself up. Stand up for the champions, for the champions. Stand up for the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions.
Thank you, Dr. Adewoyi. Thank you, sir.
For the champions, for the champions. Stand up, stand up for the champions, for the champions. Stand up, stand up for the champions, for the champions. Stand up.
Thank you very much. A round of applause once again for the winners. Thank you. It's been a long journey. Okay. Sorry, please, I'll request the pleasure of the finalists to just be seated.
Best, number one and nothing less.
Each of the other doctors are going up with a cash prize of 100,000 naira each. Each of the other doctors are going up with a consolation prize of 100,000 naira each. Please, everyone is a winner.
For the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions.
Thank you, Shalina family. Thank you all. The Shalina family, can we come up stage? Let's take our picture. Shalina family, one Shalina, one family. Please come up stage. Shalina, please come up stage quickly. Yeah, Beji, please. Olade, please come forward.
Here we go. It's getting close. Now it's just who wants
please.
it most.
Before Shalina, please,
It's
all the
just
finalists,
like
please, take your party. All finalists, please come forward. All finalists, please come forward. All finalists.
Can't you see? I'm on the move, make way for
all
me.
finalists, please come forward.
For the champions, for the
Please, all finalists.
Stand up, stand up, stand up. For the
Sanjay, come and give us some Sanjay. Sanjay will give us some dance steps. Sanjay, go and give us some dance steps.
Stand up for the champions, stand up. And when I fall down, I have to pick myself back up. And when I fall down, I have to pick myself back up. And when I fall down,
everyone has a certificate, Dr. Odede.
Myself back up. And when I fall down, I have to pick myself up. Stand up. For the champions, stand up, for the champions, stand up, stand up, for the champions, stand up, for the champions, stand up.
Again, I repeat, everyone is a winner. Everyone are going on with consolation prize of 100,000 naira. So no one is going empty. They have traveled from far and near. They have slept. They have denied themselves of quality sleep just to be here today. They have left their patients unattended to be here today. We appreciate them, and that's why we must celebrate you all. So everyone will go home with a consolation prize of 100,000 naira. Courtesy the management of Shalina Healthcare. Okay, the panelists will be taking pictures with our Shalina management, please. Chief. The panelists is Shalina management. Madam Amina,
DJ Calvin.
I will leave only for 1 minute now. Abba, please come. Can you come forward too? You are management. You are part of management. Police not. You come. Please come. You are management. Please come. Madam Amina, please. Come on for the body, no the breathe. Put on your shoe, make it stand down. All your sorrow, make it dance them free. If you know it, la 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 la. If you know it, la la la, get them food. From you want my toto, and if you know it, la la la, get them food.
Now we the puppy all over town. So tell me if you did down. Do you know? Say you want me to call like go. Girl, I know. Some things that you do not know. Whether na traffic I be go slow. Baby, I promise I go still show. Spending money, Pablo. I suppose you locate, but I I go buy Belgium. My money na alele, high pressure. But it's like she balaba, put on for high tension. You must apply your tea, big boy, you must apply plenty. Mismanage my funds on you, all I really wanna do is mismanage my funds. Mismanage my funds on you, all I wanna do is mismanage my funds.
Alright, okay. Them broke off for the voltage. Tilapia, kote. Bring a goofy with the cocaine. Obey. You see the bed, do not replay. Find a bacha for my bros. Conquer the streets with the play.
I need you building up party, all got to pump. If I run do this your body, all got so close, all got so close. If you put me for Palava, and you ball of the papa, what can they make? What be fair, ego me bed. Come me, it was this my baby. I suppose you locate, but I go buy Belgium. My money na alele, high pressure. But it's like she balaba, but I go buy Belgium. Listening totally. Now you go follow me, go party. Now you go giving me no.